Related colonic polyp by Dr. Pereris Mohan. Good evening, honorable present here. Today I will be presenting two interesting cases where we used clutch cutter upon facing a large thick-stalked pedunculated polyps under the guidance of Dr. Vinod Moser. So my main objective of this presentation is to highlight the clutch cutter assisted ESD in achieving an en bloc resection whenever we are facing a large pedunculated polyp, especially if it comes along with the high bleeding risk, and to shortly compare ESD versus snare polypectomy in a selected cases of large polyps with thick stalks. Coming to our first case is a 28-year-old female who presented with intermittent loose stools for 2 months and intermittent periumbilical abdominal pain for 2 days. Upon clinical examination, patient had pallor and peripheral examination showed no palpable lesions, and patient underwent colonoscopy which showed a large pedunculated polyp in the sigmoid colon of around 6 centimeters, consistent with Paris class 1P lesions, and ND imaging suggestive of JNet type 2A lesion. And this is the CCT image of this patient where we can see the large polyp with a thick stalk without surrounding lymphadenopathy as well as no periserosal invasions, and the patient is not in obstruction as well. On doing colonoscopy, here we can see the large polyp prolapsing from the colonic lumen, and after changing the patient's position, here we can see the polyp with the stalk, although we have only partial visualization. And upon NBA, here we can see the regular caliber vessel and tubular pattern of the surface consistent with the JNet type 2A lesion. And we did linear ultrasound, endoscopic ultrasound, where we can delineate polyp head, neck as well as pedicle separately. And upon having a closer look, here we can delineate hyperechoic mucosa and hypoechoic muscular mucosa as well as hyperechoic submucosa as well. And on applying color Doppler, here we can see a large feeding vessel extending from the base, extending upon into pedicle towards the polyp head, which can pose a significant bleeding risk on endoscopic submucosal dissection. And we begin ESD using clutch cutter. The first step is the submucosal injection with normal saline mixed with the methylene blue to elevate the lesion adequately. So we did peripherally, and upon elevating the lesion, we used a clutch cutter to hold the tissues, and by the core technique, which is by lifting the tissues in the transparent hood, and by doing pre-cut coagulation followed by cutting, we did mucosal incision from anal to oral side. Upon extending the lesion, we encountered bleeding from the feeding vessel, which is addressed with the same device without the need for exchange or the use of coag-rasper, and significantly reducing the procedure time as well. And using soft coag 40, we did pre-coag pressurization to enhance the coagulation pathway, and then we did soft coag and test the bleeding. And we extended the incision on both sides from anal to the oral side, and we did submucosal dissection using modified pocket type, where we did simultaneous submucosal tunneling as well as the extension of the mucosal incision to reach the oral side. Upon reaching the oral side, we put a final cut to achieve the en bloc resection, that is the polyp is removed in toto, and by distally opening the rock net, the specimen was caught hold of and was removed slowly in one piece. And here you can see the large polyp of around 6 centimeters. And upon having a relook, the base of resection showed no evidence of bleeding or perforation, and we decided to close the resection defect with serial hemoclips in a linear fashion. So this is the final image of the closure. And histopathology report came positive for tubular villus adenoma with low-grade dysplasia, and the base of resection is a free-up dysplasia, indicating the negative margins and en bloc resection with this device. And we had a suspicion that this young female with a huge polyp without any significant family history might have genetic predisposition. So we did a clinical exome sequencing which came positive for METOH mutation, posing the patient for a significant risk of colorectal carcinoma as well as adenomatous polyposis as well as extracolonic manifestations including endometrial cancer, and the patient is currently on close follow-up. Moving on to case 2, this is a 48-year-old male who presented with a constipation for 1 month with increased straining while passing stools and history of passing bloodstained stools intermittently. and clinical examination was insignificant, and the colonoscopy again here also showed a large pedunculated polyp in rectosigmoid junction of around 5 cm consistent with Paris class 1P, and the narrowband imaging was suggestive of genotype 2A lesion. And we proceeded with submucosal injection by peripherally injecting the methyl blue admixed saline to elevate the lesion. Here we did near circumferential incision as we had a near complete visualization of the stalk. We did the incision from anal to the oral side on either side of the polyp, that is from anals to oral side on one end, and like almost near the oral side, and on the other side also we did mucosal incision to reach the oral side using the same core technique and the RB setting endocut Q233 mode. And we did the submucosal dissection using the same modified pocket type where we used endocut Q mode. And upon extending the incision, we encountered bleeding from the feeding vessel here also, and using soft coir mode, we addressed the bleeding, and the resection was continued towards the oral side. And upon reaching the oral side, the resection was completed with the final cut to achieve the en bloc resection. And the en bloc resection was achieved in this case also, which is the primary principle of endoscopic submucosal resection. Here we can see the large resection effect. In this case, we did snare to retrieve the polyp in one single piece. And upon having a relook, these patients also showed no evidence of bleeding as well as the perforation. And we decided to close the resection defect with a serial of hemo clips in this case also. So we used in total of around 6 clips in this patient, and this is the final image of the closure. So we chose ESD over snare polypectomy in this case. When it comes to the topic of ESD, there are more and more studies from the East Asian countries, especially from the Japanese countries rather than from the Western countries, and the results are also good from the East Asian countries. Some of the famous studies quoted the difficult pedunculated polyp lesions as polyp size more than 3 cm with poor visualization of the stalk. That is a technical difficulty. And if we chose a snare polypectomy in this case, which has around 5 to 6 cm the polyp head, we might face a difficulty in garlanding the snare over the polyp, as well as endoloop assisted snare also we might face difficulty in garlanding the loop over the polyp head. And upon linear ultrasound, in the first case, we have seen the large feeding vessel, which might pose a bleeding risk, significant bleeding risk. If you use the snare, the bleeding rates might be high. And the Japanese studies showed a high en bloc rate in ESD of around 5.5% in a 5-year follow-up studies, especially if a polyp is more than polyp stock is more than 20 mm. So there are studies which compares directly with the scissor type knife to the non-scissor type knife for ESD, especially in colonic polyps. There are multiple studies, around 1,800 patients were included in this meta-analysis, which showed there is a significant decrease in scissor type knife, as well as increased outcome with a low risk of perforation as well as bleeding. Although there are conflicting results in some major studies also that shows non-scissor type endoknife has decreased procedure time than scissor type endoknife, but those studies also quoted there is a low risk of perforation as well as bleeding. So some of the note about clutch cutter. Clutch cutter is a novel scissor type endoknife designed especially for grasping and lifting the tissues, and using electrosurgical unit we can cut the tissues, and it comes in two ways, depends upon the knife length, that is 3.5 and 5. The working channel and the working length are same for both. And coming to the electrosurgical properties of clutch cutter, the clutch cutter is unique that it has an inner electroactive serrated margin, but the outer insulated sheath. So the inner electroactive serrated margin grasps the tissue away from the muscularis propria, as well as outer insulated sheath decreases the conduction of electricity, so that both significantly reduces the deep mural injury to the tissues, significantly reducing delayed perforation. So these are the basic steps of ESD with clutch cutter. That is, first is submucosal injection to lift the tissues adequately from the muscularis propria, and mucosal injection was begun. Depends upon the visualization of the stalk, we can do complete circumferential incision or semi-circumferential incision, and there are various types of mucosal dissection are proposed. The pocket type is one of most famous type to did submucosal tunneling in case of a polyp, and the final cut to made a resection to achieve en bloc resection is done. And advantages of clutch cutter, it is a 3-in-1 integrated function. It performs incision, dissection and hemostasis all with a single instrument without the need for exchange, significantly decreasing the procedure time, as well as we can lose the visual field also because of the blood use, so that with this device we can address the hemostasis on time. And the regrasping and 360-degree rotational precision is one unique advantage of clutch cutter, where it allows regrasping to allow precision, as well as the 360-degree rotation also allows miscutting, and it also avoids deep renal injury thanks to the outer insulated sheath. Overall, it is a type saving efficiency, as well as it also achieves the en bloc resection, which is the primary principle of ESD. So, in conclusion, ESD, the clutch cutter for ESD has to be chosen on a case-to-case selection basis. Even in the hands of less experienced endoscopist, the clutch cutter have been shown to have decreased complications, especially in terms of perforation and bleeding. So apart from all this property, the main aim of this presentation is to highlight the one thing, that in India it's not the difficulty to achieve the skills or bring the techniques, but bring the highly advanced techniques to the plates of poor people. And this clutch cutter is one novel device which achieves that indication that clutch cutter can be used to at a lower cost to achieve an en bloc resection as well. So thank you TNSG, and thank you GEM Hospital, and I thank Dr. Vinod sir for giving me this opportunity. Thank you.
Good presentation. So you used the EST technique because pedunculate polyp we always put a snare and loop, You used it because the snare cannot go
over the polyp
into the polyp. How do you make the polyp smaller to allow the snare to go inside?
We can do trimming of a polyp head, sir. Trimming of the polyp head can be done to allow the snare to garland over the stalk, but it may result in a piecemeal resection, again posing the patient for close follow after 6 months. And it also misses some intramucosal invasion or intramucosal carcinoma as well. And we can use in therapeutic channel, we can use on one side we can use a snare, and another side we can use forceps to grasp the polyp to garland, but for a 6 centimeter polyp it's quite difficult, I think.
Yes, okay. I mean, sometimes you can use a bigger snare, you can do a piecemeal resection, you can also inject adrenaline into the base, and then it will go inside. Sometimes we use a larger clip, 2 different clips at the base, then the polyp will shrink, the snare can go. Any other? So you said clutch cutter has a insulated side, so current doesn't. Where all current can spread?
Sir?
Where all current will go to wherever it has a. Suppose if the polyp is touching the opposite wall, current will go there also. It is not that it goes through the instrument alone. It can go through the polyp. So when you are using high current, you should be careful that the polyp doesn't touch the opposite end. But nowadays the electrocautery machines are brilliant. So sometimes if the conduct area is too much, it doesn't deliver the current also.
I have no question, I can lead.
Good.
First case, there was a big vessel was going around the base of the polyp. We thought of putting an US guided, glue first and then followed by a polypectomy. Yeah, US guided. You saw the US image, sir. a big vessel was running from the stalk to the, head of the polyp.
That is the problem with the peduncle polyp. All the blood supply to the large polyp go through the small pedicle. Usually the pedunculated polyp has the biggest vessel. If it is a flat polyp involving a large area, blood supply go through multiple vessels. The bleeding chances are there, but then it can be controlled. If it is a pedunculated large polyp, there will be always one or two very big vessels, and if it bleeds, it's quite difficult.
Initially, we thought of doing in conventional EST because of this large stock. In fact, there are case reports which shows that Dr. Radhika Chavan has reported putting a glue inside the, a big vessel and then doing an EST. We thought it's not cost effective. We have to get a needle, a glue. So we thought of using a clutch cutter so that we can see the,
Compared to the needle and glue,
clutch cutter, it's a multi-use, yes, definitely. We have used one clutch cutter almost for 5 to 6 cases, which cost only 40,000 rupees. It is very cost effective. Doesn't only you have to close with the clips, right? That's why we used. It's already done, madam.
Thank you. I call upon the next speaker, Dr. Ashwin from Stanley Medical College, to present a case on prolonged hepatitis, how to proceed.
Good evening, respected senior faculties and PG colleagues. I am Dr. Ashwin from Stanley Medical College. So my topic is prolonged hepatitis, how to proceed. So the patient is a 17-year-old boy who is a 12th standard student from Chennai. He presented with complaints of low-grade fever, malaise and myalgia, which lasted for 2 days before recovery, followed after 5 days by yellowish discoloration of eyes and urine. This happened 4 weeks prior to he was healthy 4 weeks ago. There was no pain abdomen, pruritus, clay-colored stools, and no altered sensorium and bleeding manifestations. There was no skin rashes, joint pains, no ataxia, tremors, speech or gait abnormalities, and no behavioral and psychiatric symptoms. Past history, he apart from he is a known case of bronchial asthma and intermittently uses MDIs. And other than that, no known comorbid illnesses, no past surgeries, no CAM intake, no history of IV drug abuse, alcohol, smoking, blood transfusions or tattooing, and he was also vaccinated up to his age. Family history, he is a second born child of a non-consanguineous marriage couple, and he has an elder sister who is 23 years old, and there is no similar history in the parents or the siblings. So he initially presented to our center in the Department of General Medicine, and he was at the time afebrile. There was no features of encephalopathy or coagulopathy, and he told that his jaundice had worsened. On examination, during the first presentation, his vitals were fairly stable, and he was conscious, sensorium was fine, and he had an icterus. Abdominal examination revealed hepatomegaly, which was firm, tender, and around 3 cm below the right coastal margin, and there was also mild splenomegaly. Other systemic examination, including the neurological examination, was normal. So initial investigations showed a normal CBC, INR, and RFT. Coming to LFT, there was direct hyperbilirubinemia of around 12 and 8.1 direct bilirubin. OTPT was also significantly elevated in the thousands range of 1200 and 1600 OT and PT respectively. ALP was also ALP was 210. Subsequently, after 5 days, the repeat investigation showed a fall in bilirubin of up to it came down to 7.2 and 5.3, and OTPT also had come down drastically. He was symptomatically better also. They tested for IgM hepatitis A, which was positive, and other viral markers were negative. A peripheral smear also was obtained at that time, which showed a normocytic blood picture and no evidence of hemolysis. He was diagnosed as a case of acute hepatitis A and managed conservatively. Over the course of hospital stay, patient improved, and as I mentioned, bilirubin and AST and LT was coming down, and no features of liver failure also. So just prior to discharge, he had bilirubin of around 2.6. OTPT also came down to 130, 145. ALP was 188. INR was normal. So he was discharged and asked to review after 2 weeks. But when he came for review, he told that he had worsening of jaundice, and that's when we started seeing the patient in medical gastro. He also had loss of appetite, occasional vomiting, not bloodstained, food particles mainly. No pruritus or pale stools. And investigations showed increase in bilirubin, which started increasing from 2.4 to 10.5 now, and OTPT also had started rising again. Now OTPT around 1500 and 2100 range. ALP became 308. Other investigations like RFT, INR and CBC were normal. Here again had ectosplenomegaly, same findings were there. Other systems were normal. Ultrasound was taken, showed mild hepatomegaly and splenomegaly. No IHBRD and CBD was of normal size. After evaluation was done and it was normal, there was no KF ring seen. So we considered the possibility of, since IgM hepatitis A was positive and the clinical spectrum was fitting, we considered hepatitis A associated relapsing hepatitis, hepatitis A associated cholestatic hepatitis, all because ALP was increasing, but although he did not have pruritus, I had to mention. Other infections like tropical and atypical viral infections were also considered, and the AIH also was considered.
Yeah, can you justify each of your differential diagnoses here?
First thing, the patient had an evidence of hepatitis A. The typical clinical picture along with the IgM seropositivity was there, and then patient improved. Followed by again patient had a relapse of symptoms. So we considered hepatitis A associated relapsing hepatitis because of the relapse. And again, patient had again hepatitis. So that was why we considered it. The second possibility usually we seen with hepatitis A is a prolonged cholestatic phase. So that was second possibility considered. But the patient did not have pruritus. That was against. But ALP was high, sir.
LFT is not favoring acute hepatitis B going into cholestatic pattern. Your second LFT.
Yeah. Alkaline phosphatase began rising.
It is a new event rather than an ongoing acute hepatitis B progressing into cholestatic hepatitis. Other
we also, I was coming to it actually, we considered infection, sir, and we...
in your differential diagnosis, yeah, go next slide.
There was no pruritus, no, not there.
You just check KF ring. Any other differential diagnosis you want to?
We are also considering Wilson's. I was coming to that. Autoimmune hepatitis can also be a manifestation of hepatitis A. It can be an atypical presentation also. So you started on supportive medications and we started working up for cause of prolonged hepatitis. So infective workup was done and IgM lepto was positive. MAT was we could not do because of we were not doing in our center. The other infective workup like smear for malarial parasite, blood culture, scrub typhus, dengue was negative. And atypical viral infections were also ruled out. Autoimmune workup was also done like ANA, anti-LKM, SMA and SLA were done, which are all negative. So since the IgM positivity was there, we started the patient on doxycycline given for 10 days, but still the LFT was still increasing trend only. So bilirubin had increased to 29 and 18 total and direct respectively, and OTPT was also still elevated. It was around 1500 and 782, all those mild decrease only. And ALP it had gone to 300 and then slowly come down to 99. Other investigations were RFT, PT, NR and CBC were normal. But SGPT was found, SGPT was initially more than OT, but later on it became the reverse, that is OT became more than PT, but ALP in the second investigation on 10th, it was found to be that on 20th the investigation showed that ALP bilirubin ratio was less than 4. So we also suspected Wilson's disease and worked up for that, and ceruloplasmin was found to be low, that was 19.6, and 24-hour urine copper was high, around 127. So we tried to put the modified Leipzig score, which was coming as 3. So possibility of Wilson's could not be ruled out, so we still considered a possibility of Wilson's. We started the patient on D-penicillamine 250 milligrams BD and discharged and asked to review. And on review, patient showed improved LFT parameters, which not entirely attributable to Wilson's itself, but needs further workup to rule out Wilson's, like MRE brain, sibling screening also was planned after patient's investigations, genetic test also. So this is the latest investigation which shows that patient's LFT had, in the latest visit, the bilirubin had come down to 4.1, 2.5 and OTPT had come down to 120, 101. Other investigations were normal. I'm sorry. So to conclude, infections like hepatitis A could unmask underlying Wilson's disease, so there should be a high index of suspicions for Wilson's disease. Previous articles in South Asian region showed similar studies, where this article shows undiagnosed Wilson's disease presenting as a liver failure after hepatitis A superinfection. And another article also done from Turkey also has similar findings. Thank you. We have not diagnosed, ma'am. We are just keeping that possibility.
When you're keeping a possibility, then where do you start on D-penicillin?
The classical presentation of hepatitis A in adults, that's that was 6 months ago, liver failure, steroids are given for such patients. Steroids water taking place, and that's how A behaves in an adult. That's classical. This is classical hepatitis A. Label this as Wilson, and lifelong is going to worse this. It's something like Crohn's now. Label once as Crohn's and lifelong you go. This is not Wilson disease.
No, we have not labeled.
You cannot even consider that even in your discharge summary should not mention Wilson. This is classical hepatitis A, cholestatic features. We have seen patients going up to 6 to 9 months. Give a small dose of steroid and the whole thing, the patient just settles down. And this is classical. AST, ALT, will you get that high in elevation in Wilson disease? Is it acute liver failure? Only in acute liver failure due to Wilson disease you will get such high values. So even in your differentials, you should not consider that possibility at all. It's a dangerous discussion, you know. And what happened to HAV IgG? Has it come up now? Has it surfaced?
No, we did not do IgG.
That is important, no? Maybe the IM is still persisting.
Yes.
IgM. Are you thinking of one disease or two diseases? This is just one disease in this patient.
Sir, what I'm saying is there could be underlying Wilson's, but which got manifested because the patient had an hepatitis A infection. So that is what. Yeah.
But did you give steroids?
No, we did not.
That would be a simple solution, no?
Yeah.
Because your branding company, as Madam said, is not required. Because the patient is going as a lifelong Wilson disease, it is totally incurable. Hepatitis is a self-limiting disease. Why you want to brand him as a Wilson? It's totally unwarranted.
Okay.
So give us steroids, wait for some more time, he's not going to die.
Yes, ma'am.
But this is classical case, to other
As Madam said, don't put a diagnosis themselves in a self-limiting disease.
Yes, ma'am.
It's a chronic illness and because if you put a diagnosis, you must keep on going.
You don't give importance to low steroidoplasmin and high
Not at this level.
Steroidoplasmin is not low, sir. This is not, we don't know this is low, sir. We don't know. 19 is just borderline. Just borderline. We don't take it as no.
So whatever it is, we can do after the.
We can wait for some.
If you start D-penicillin, it's for life. So when you plan, what is the plan for this?
So we want to confirm Wilson's by genetic analysis and to see.
But why do you want to treat before?
Genetic analysis comes negative, you are going to stop or you are going to continue?
Will not consider the diagnosis of Wilson. We'll see the.
It will be written in the file. Known case of Wilson disease, complaints of vomiting. Known case of, I think not. That's not fair. Actually, you should, if you want to write Wilson disease, you should do more tests to confirm it and then label him.
And of late, we are finding this urine copper is becoming more than 100, that's where we are getting lost. and patients are getting labeled. We had a patient at the age of 12 years had similar symptoms, and the patient was being treated for 8 years as Wilson disease in one of the institutions. And then he developed hepatitis, all negative, became positive, LK became positive. Now we do not know if deepen caused it, or actually we were not dealing with Wilson at all in the first instance, because the workup for serology for AIH was not done in the first instance. And he went on as Wilson for almost 9 years. Parents went in for this thing, everything, and genetics became negative, all were negative. But urine copper still today is 140 in 24 hours. So I think some of you should tell them for the pediatric age group, this urine false, I think there's a lot of false positive, or is it a reaction and then the person has excess?
If you want to start depenselamine, then I think you should do the depenselamine challenge. Look at the urine copper, give depenselamine for 5 days, repeat and see if it's 3 times, then you start. Now, I think to start depenselamine in this individual would be unwarranted.
I do have an opinion. So the issue is, I would have done a liver biopsy if I had any kind of suspicion. Because that would have kind of clarified the diagnosis. You'll know whether there's lobular hepatitis, you'll know whether there's copper accumulation, you'll know whether there's evidences of autoimmune hepatitis.
Because of that virus may not have completely cleared, sir, so that
virus gets cleared once a jaundice present. It is not the persistence of virus which causes. Normally, virus gets excreted in stool only before the onset of jaundice. Once jaundice comes, virus gets cleared. Why there is a jaundice in viral hepatitis?
because of
Response to the virus.
Thank you, Dr. Ashwin. Is Dr. Ilanchalian here? Yeah. Next, I call upon Dr. Ilanchalian from Madras Medical Mission to speak upon a difficult case of recurrent obscure overt GI bleed.
Very good evening to my respected seniors and my colleagues here. I am Dr. Ilanchalian from the Madras Medical Mission Hospital, here to discuss a difficult case of recurrent obscure overt GI bleed. So we had a 64-year-old male patient from Chennai who is a bus driver by occupation, as a known case of systemic hypertension for the past 10 years, who had initially presented to us in 2018 with chief complaints of passing black tarry stools for 5 days. He had 2 episodes of black tarry stools associated with bilateral shoulder pain and giddiness as complaints. So that was the main complaint. Patient had no history of fever, abdominal pain, vomiting, unintentional weight loss, or anorexia. He had no history of abdominal distension or any lump in the abdomen. He had no history of CAM intake, NSAID intake, or recent change of medication also. Patient had no history of altered sensorium, no history of involuntary movements or behavioral changes, no history of recurrent oral ulcers, redness of eyes, hair loss or skin ulcers, and no history of chronic cough, expectoration, or evening rise in temperature, and no history of chest pain, leg swelling, breathlessness, palpitations, and no history of tattooing. In past history, patient had a history of similar episodes present occurring for 5 days in a month for the past 2 years on and off. And he also had a history of recurrent epistaxis in his adolescent years, but the treatment details for those were not available. And he's a known case of systemic hypertension for the past 10 years on tablet metoprolol 25 mg OD. And he has no history of surgeries in the past. Patient is married with 2 children, and he denies any form of addiction and no history of any high-risk behavior, and no history of similar illness among family members, and no history of cancer among family members. And he's taking metoprolol for systemic hypertension. Nutritional history: patient consumes mixed diet with 1,619 kilocalories per day. He's deficient by 64 calories for his weight, and 30 grams of protein per day, which was deficient by 12 grams. So this was a 64-year-old male who's a known case of systemic hypertension with no surgeries in the past, who's a teetotaler, a non-smoker, had a recurrent history of GI bleed in the form of melena since 5 years, now presented with melena, giddiness and bilateral shoulder pain since 5 days, without any history of fever, weight loss, abdomen distension, abdomen pain, vomiting, altered bowel habits, with a ECOG performance status 0. So, on examination of this patient, he was conscious and oriented to time, place and person. The hydration was fair. He was afebrile. He had significant pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no lymphadenopathy, and there were no cutaneous markers of internal malignancies. His height was 167 centimeters, weight 70 kg with a BMI of 25.5 kilograms per meter square. And pulse was 88 per minute, regular in rhythm, volume was normal, equally felt in all extremities. BP was 140-90 millimeters of mercury in the left arm, supine position. Respiratory rate 18 per minute, and saturation was 99% in room air. On examination, per abdomen, inspection was normal, umbilicus was midline, all quadrants were moving equally with respiration, there were no scars, sinuses or visible veins. The hernial orifices were free and genitals were normal. Palpation, there was no tenderness and no organomegaly. Auscultation, bowel sounds were audible and normal, no hepatic bruit or other added sounds. And per rectal examination, there were no perianal lesions, and gloves were stained with blackish stools. And other system examinations were also normal. So we proceeded to investigate the patient. He had a hemoglobin of 4.7, which had dropped from 11.2, and a total count of 5,200 with platelet of 1.2 lakhs. His MCV was 67 and MCHC was 29.5 with a PCV of 24.1 and TSAT of 11%. And the peripheral SME was showing microcytic hypochromic anemia with anisopoikilocytosis. His RFT and electrolytes were all normal, and LFT was also normal. So we proceeded with a USG abdomen, which showed a mild coarse echoes in liver, and we did a 2D echo, which was a normal study. And coagulation profile, BTCT, PTINR, and APTT ratio all were normal. So patient had an upper GI endoscopy, where in the fundus of stomach we noticed active ooze with altered blood, and there was a small nipple-like elevation on the fundal mucosa, and surrounding the nipple-like elevation we could see a visible ooze. And for this we had done a sclerotherapy since there was a continuous bleeding with a heater probe cautery, and the bleeding was arrested, and this was the post-sclerotherapy image showing the ulcer. So after that, patient did not present to us for the next 6 years, but in 2025 February he came back with again complaints of melena of 5 days, and this time HbA dropped again from 12 to 5.6. So again we had proceeded with doing an upper GI endoscopy, where the body showed a mucosal edema with subepithelial hemorrhagic spots over the greater curvature, and there was also a tiny vessel in the body, this time with signs of recent hemorrhage. So this time we had placed a hemoclip at the suspected dilulofoil lesion, and we also did an APC to control the bleed, and we had discharged him. But again he had come to us after 2 days with same complaints, with again hemoglobin drop, and this time we had done a colonoscopy, which was showing normal study. We had seen up to 15 centimeters of terminal ileum, and further we proceeded with a capsule endoscopy, which showed a few angiectasia, gastric angiectasia, and few ileal erosions, but there were no signs of active ooze. So we proceeded for a CT abdominal angiography, where there was a diffuse wall thickening of the greater and lesser curvature of the stomach, with a prominent vessel supplying the lesser curvature from the left gastric artery, but there was no obvious extravasation. And on then he came back on July with the same complaints, and this time patient had gastric and duodenal erythema with angiectasia. So this time we proceeded with doing a APC for the angiectasia. So OGD was showing gastric erythema and edema, and then we had to take since the edema was there, we had taken biopsies from the body, antrum and incisura, which revealed chronic inactive antral gastritis only. So CECT at this time we had done, which showed a suspicious small focal area of, it was a query extravasation or a blush of contrast into the distal jejunum or proximal ileal lobe. So we proceeded with RBC scintigraphy, which showed active bleed in the proximal jejunal loop in the SMA territory. So we had to do a DSA, and this blush in the SMA territory was noticed, and we had done a coiling with the help of the interventional radiologist. So this was a gastric erythema. And after this, patient had no bleeding complaints, so he was discharged again. And again after 3 months, he came with the same complaints and anemia. And again endoscopy was proceeded, and he had a portal hypertensive gastropathy and duodenal angiectasia this time, which was not evident in the last upper GI endoscopy. So we had repeated the CT abdominal angiogram, which showed a focal blush of contrast extravasation in the jejunal branch of SMA in the intraluminal part of distal jejunum in the left iliac fossa. So this time we had proceeded with glue embolization after seeing the contrast extravasation, the DSA. And we had spoken with the patient, we had started octreotide depot injection, 20 mg IM, and also thalidomide, tablet thalidomide 50 mg BD for the angioectasia. So even after starting, for 4 months, patient did not have any complaints. Again in this March, he came back with the same complaints and drop in hemoglobin. And this time CT showed a prominent cecal submucosal vessel. It was a query. So we had done a upper GI endoscopy, which was normal, and colonoscopy that we had done showed a fresh blood proximal to that's bleeding from the IC valve. So it's probably a small intestinal source of bleed. So this time we had taken the general surgical gastro opinion, and patient was taken for laparotomy. And on laparotomy, we had at 30 centimeter distal to the DJ flexure, we noticed an area of serosal ulcer with stricture with neovascularization. So enterotomy was done, and we noticed a mucosal ulcer with bleed. And we did an on-table enteroscopy, and we visualized the bowel proximal and distal to the ulcer, which showed no active bleed or ooze, but there was only active bleeding from the ulcer side. So we had done a small bowel resection and anastomosis 10 centimeter proximal and distal to the stricture, and the biopsy showed a small bowel angioectasia with no evidence of dysplasia or malignancy. So this time we had also done a vasculitis panel with C-ANCA, P-ANCA and complement to check whether we are missing something, but all went negative. So the intra-op findings where patient had this stricture and an ulceration on that side. So this site, when we correlated with the CT again, this was the site where patient had underwent coil embolization for the first time. So we thought it was maybe probably due to the coil induced ulcer, but this was more of an angioectatic bleed. And for POD 12, and for the past next 10 days, patient did not have any bleeding or a drop in hemoglobin. But again, the recurrence of melena took place, and patient this time had hypotension and significant hemoglobin drop of 4. And the CT angiography again did not reveal any contrast extravasation or any leak from the anastomotic side. And we had repeated an RBC scintigraphy 2 weeks back, and active GI bleeding in the proximal jejunal loops in the left lumbar region was noted. So last time it was in the distal, now it's in the proximal jejunal loop. And this first jejunal branch was coil embolized with 4 coils this time. And even after that, patient developed an episode of hematemesis, which was the first time he is presenting with hematemesis. And we had done an OGD for hematemesis, and in the fundus, we noticed a prominent submucosal visible vessel with active ooze. It was similar to the area where we had initially seen the first presentation, we had seen this lesion, and we had placed 2 hemoclips along with sclerotherapy. But on relook OGD also, patient had persistent ooze from this vessel, and we had planned to take the patient for surgery to do an undermining of the vessel, but patient were not willing for that procedure, so we had to go for a DSA again. And this time we had noticed an abnormal blush from the fundus from the left gastric artery branch and short gastric artery, and we had to embolize with PVA particles. So this embolization was done yesterday, and currently the patient is still having bleeding, and we could not able to arrest the bleeding of it's coming back in different places every time that day. So we are still in a dilemma of how to proceed next now.
Have you
shoulder pain and that platelet count was 1.2. Did you repeat it later?
We had repeated when it came out to be normal, like 1.7. Like every admission we had repeated, it came out to be normal.
So do you have a flush CT complete angiogram of the aorta?
Yes.
Do you have any pictures on that? Does it pick up any small aneurysms or any such lesions?
We had done a total CT angiogram, but it did not pick up any aneurysm or any signs of vasculitis.
Any workup done for a platelet aggregator defect? Because this kind of bleeding episode where you have any major source, so you should always look for any hematological disease. One thing is Glanzmann's thrombasthenia, where you have a platelet aggregator defect. You have a mucosal, these kind of defects in the stomach or jejunal mucosa, they can bleed recurrently. Okay. That is worthwhile trying a Glanzmann's thrombasthenia. Because why I am saying is, I have a similar patient who had a recurrent bleeding, but finally turned out to be a Glanzmann's thrombasthenia.
that you need electron microscopy to find out platelet functional abnormalities. That's what sir is saying. And again, this patient also had recurrent epistaxis. You said that's all the more reason why you want to check platelet functional abnormalities, and also other things like von Willebrand factor. You said there was no aortic stenosis, but I think that should have been cross-checked. Check von Willebrand factors and other factor deficiencies. Okay. Coagulation workup could have been done for this patient, which is very unusual to find different locations in different endoscopy and causing overt GI bleed. Yeah, thank you.
Is it fitting into any of hereditary disorders, Osler-Weber?
It was not fitting into any of those. No.
Discuss that, no? Because those are the ones that TCR.
Okay.
Do you have any information? I remember seeing one blue rubber knee was presenting like this, recurrent bleed. Hereditary, HHT. Those are
Osler-Weber and do.
Yeah, those are the ones that you have to check.
Okay.
Doctor,
If you are suspecting DLO5 lesion, I don't think these DLO5s will be controlled with conventional hemoclips. We have to go for an OTSC clips. I feel it's in diffuse angioplasia which is causing all this.
Okay.
Doctor, one bleeding, you saw the bleeding from the jejunum in the CT scan and during surgery also. Rest of several episodes explained in the initial presentation, stomach, I saw red blood. You presumed that was a bleeding spot, but you never saw the blood. How do you know it is upper GI bleeding at all? It could still be a jejunal bleeding. See, upper GI bleeding can be confirmed only if you somehow demonstrate blood in the stomach or in some CT or during endoscopy. Otherwise, just by seeing a red spot, presuming it is a visible vessel and doing something and getting better, sometime it may not be the...
Yeah, why pre-op enteroscopy you did? Yes. You did intra-op enteroscopy.
Yes.
If you had enteroscopy, you could have done, because this lesion was not very far from DJ flexure according to you. Why enteroscopy was not done pre-op?
Initially, we didn't plan for the enteroscopy, double balloon enteroscopy, because patient was a severe hypotension, sir. So they preferred from the surgeons.
You took him for surgery.
Yes.
I think the anesthesia required for surgery will have more adverse effect on hemodynamic instability than doing an enteroscopy. And probably that bleeding is from the coil site, the second time.
Okay.
Doctor, I have a question.
He suddenly start having this problem at the age of 64. 64, no?
Yes, sir. 50.
So how do you explain that? All along he's okay for 64 years and suddenly all the vessels.
That's
Is it the hypertension?
Aortic stenosis.
Hypertension. Maybe it's
one
hypertension.
condition, Heady syndrome.
Yes, but
can have
echo was normal.
Echo was normal.
So why did you do, what is the advantage of RBC scan versus conventional angiograph? What is that, are advantages and disadvantages of a RBC scan?
Advantages when the bleeding rate is less than 0.5 ml per minute, RBC scintigraphy picks up, and conventional CT angiography picks up the bleeding only if it's more than 0.5 ml per minute, and that is how we missed once, like the bleeding was very less, so we missed it.
I think
you are
that,
telling wrong values.
If RBC scan, you are giving a radiologically detectable substance in the blood. Sometime when you do first time, it may not be there bleeding. So RBC's life expectancy is 3 months, So you can repeat the scan for a month whenever you think there is a bleeding. That is the advantage of RBC. Otherwise, you can use albumin, which is a shorter half-life.
Thank you. That was a difficult case. Nice presentation. Next, call upon Dr. Kiran from Apollo Hospitals to present journal scan on review of recent publication from India on pancreatobiliary disorders.
Good evening, teachers and colleagues. and I will be presenting recent publications on pancreatic biliary disorders by Indian authors. I will be presenting about 6 studies in this presentation. First is a study published in World Journal of Hepatology in February 27, 2026, and it was conducted in AIG Hyderabad. Here they compared the latest generation extracorporeal shockwave lithotripsy versus laser lithotripsy for difficult bile duct stones. So the aim was to evaluate and compare efficacy and safety of ESWL with the latest Darnier Delta 3 system and and of laser lithotripsy using a single operator cholangioscope. It was a retrospective cohort study. The population included 458 patients with difficult CBD stones that could not be removed by standard ERCP techniques. Group A had 387 patients and Group B had 71 patients. Propensity match was done for the study. The difficult stones were defined as stones more than 15 millimeter, multiple, associated with a difficult anatomy structure, short or sigmoid CBD, acute angulation, impaction or presence of stones in unusual locations. And in the Group A, ESWL done with the Darnell Delta 3 third generation electromagnetic lithotripter with a subsequent ERCP for fragment clearance. And in the comparison arm, laser lithotripsy was performed with a spikeless single operator cholangioscopy using YAG laser. The outcome measured were, for the primary outcome, complete CBD clearance, which was confirmed by ERCP cholangiography. And the secondary outcomes are compared a number of ERCP sessions needed for clearance, procedure-related adverse events such as cholangitis, pancreatitis, post-sphincterotomy bleeding, and a need for additional interventions, including surgery. The time of this duration of the study for patients from 2019 to 2022, it was taken from their database. The overall results showed that both this ESWL and single operator cholangioscopy had a similar stone clearance, procedure burden, complication rate, with all p-values more than 0.05, indicating no statistically significant difference between the two treatments. This ESWS has a better CBD clearance of 95% compared to its previous generation models, which was about 70 to 80%. And the overall complications was also comparable. Nothing was better than either. So the conclusion, both are highly effective, similarly safe for difficult CBD stones, achieving more than 95% clearance and low complication rates. So the choice of the procedure will be based upon the financial and expertise available in the center. Going to the next study. This study is again done in AIG Hyderabad, published in Indian Journal of Gastroenterology in February 2026. And this is reintervention in US guided wall of necrosis drainage with metal stents. They were identifying high risk morphologies for this. So this is also a retrospective cohort study. And population was adults of 500 adults with symptomatic wall of necrosis from acute pancreatitis. All underwent US guided drainage with metal stents. The lamps are biflant metal stents at a single tertiary center. The intervention index procedure was US guided drainage of one using metal stents, hot access, NAGI or hot spaxes. And the variables are interest evaluated were demographic, age, etiology, severity, ICU admission, and organ damage, and other morphological characters of the wall of necrosis such as size, paracolic extension, percentage of solid debris. The comparison, patients not requiring reintervention versus those who required reintervention after initial drainage. Also there was an internal comparison between different morphologies such as small, large, with or without paracolic extension, and lower and high debris. So the outcome which was measured is how many of the what characteristics led to the patient needing extra procedure for after initial drainage of wall of necrosis, and what predicted these reinventions. And again, the primary outcome for need for reintervention, such as for unclogging of the stent, direct endoscopy, necrosectomy, nasocystic tube, percutaneous drainage, or need for surgery. Secondary outcome was identification of independent predictors, and the period of study was from 2023 to Jan 2023 to December 2024. So at the end of multivariate analysis, they found that larger size, paracolic extension, and higher solid debris, those are the only predictors of predictors of reintervention. The reintervention rate was 24%, needed at least 24% of the patient needed at least one reintervention. 76% were managed with drainage alone. Age, etiology, severity, ICU admissions were significant in univariate analysis, but in multivariate analysis they were not significant. The commonest reintervention was for unclogging of stent, followed by nasocystic tube, necrosectomy, percutaneous drainage, and surgery. The 76 of the patients who did not need a reintervention were discharged within 72 hours with only short antibiotic course, and overall the patients were followed up by telephone calls. So again, the conclusion same: larger size, paracolar extension, higher necrotic content are independent predictors of needing for reintervention after EUS guided metal drainage. Why this is important is the recognition of these factors will help us in planning either a step-up approach in such patients and for the overall outcomes and counseling and resource planning. Next is it's a multi-center study comparing fluoroscopy-free direct solitary cholangioscopy versus ERCP for clearance of non-complex biliary stone. It was a non-inferiority randomized control study published in gastrointestinal endoscopy in 2026. So again, so the population, it is randomized control trial, included 250 patients with age more than 18 or above 18 years with symptomatic choledocholithiasis, having abdominal pain or abnormal liver enzyme, a non-complex biliary stone with less than or equal to 5 stones, each 10 mm or lower in CBD or common hepatic duct, and a duct diameter less than or equal to 12 mm on a pre-procedure imaging. The pre-procedure imaging could be ultrasound, MRI or CT abdomen, in a group A undergoing ERCP, 126 patients are recruited. In the direct cholangioscopy patients, 124 patients are recruited. So after in the intervention, again as I told, direct solitary cholangioscopy was done for stone clearance, and post procedure the clearance of stone was validated by ERCP occlusion cholangiogram. In comparator arm, standard ERCP was done with fluoroscopy, and post procedure validation was done by cholangioscopy. In the intervention arm, if there was a doubt of biliary cannulations, they were allowed to have a brief they were allowed to have fluoroscopy for a brief few seconds, but if the fluoroscopy was used for confirmation of the position, the primary outcome was considered to be failure. However, for secondary outcomes, they were included for analysis. So the primary outcome, there was complete stone clearance in the index procedure validated by the opposite modality, and the secondary outcome was radiation exposure, fluoroscopy time, dose and dose area product, procedure duration, device or procedure related adverse events by severe adverse events by 30 days. The time frame was outcomes of an index procedure and 30 days of follow with phone calls at 1 day, 7 days and 30 days. So the primary and secondary outcomes comparing group A, second B are summarized overall. So the primary outcome, which is complete stone clearance, was 88.9% versus 87.1% with a difference of 1.8% with upper 95% confidence interval of 8.9. They have set a non-inferiority confidence, upper 95 confidence interval of 10%. So it was confirmed to be non-inferior. That is the direct solitary cholangioscopy was non-inferior compared to the to standard ERCP in complete stone clearance, and as expected, all the median fluoroscopy time, median radiation time, and median dose area product was significantly lower in cholangioscopy, direct cholangioscopy arm compared to the ERCP arm, but the mean duration period was about 10 minutes higher in the cholangioscopy arm. So conclusion: fluoroscopy-free direct cholangioscopy is as effective and as safe as standard ERCP for clearing non-complex biliary stones, while reducing the radiation exposure, but about 10 extra minutes per procedure. At high volume center with experienced endoscopists, this can be considered as a viable alternative for non-complex biliary stones. Next. This study, coming to next study, this is a prospective clinical validation of a novel artificial intelligence system for real-time detection of solid pancreatic masses in patients undergoing EUS. This was done in Digestive Health Institute, Orlando Health in Florida, United States, and published in March 2026 Journal of Endoscopy. The Indian authors were Dr. Shyam Vardhalaju and Dr. Jayapal Ramesh, who were the primary EUS consultants who did this procedure. So the new artificial intelligence imaging system was called as Pancreas AI-US for detecting pancreatic lesions. So this is a prospective single center randomized comparative study in a real time at a tertiary referral center. Again, the population total N was 308 with adults more than or equal to 18 years referred for EUS evaluation of suspected pancreatic lesions, either solid or cystic. Because of symptoms, radiology or laboratory findings are high genetic or familial risk for pancreatic cancer. So the intervention arm had the AI-US using the pancreas deep learning system, and it was compared to conventional EUS performed the expert endosonographers. So the analysis was done in the same setting. EUS was being performed by the EUS expert, and in another room this was. The relay of the EUS video was shown to another endoscopists who were noting down the findings of the artificial intelligence reports. So the outcome is to detect this and segment the solid pancreatic mass lesion with EUS real time. Secondary outcome was to evaluate how it is good at detecting the cystic lesions and normal pancreas. For the primary outcome, mainly solid pancreatic mass lesions were considered. For secondary outcome, pancreatic cystic lesions and normal pancreas was considered. This is a prospective real-time clinical validation study, and a recruitment and evaluation from January 29, 2024 to July 5, 2024. So among the 308 patients, 105 had a solid pancreatic masses. EUS was able to the AI system was able to find in 97.1% of the cases with no statistical significance, and the accuracy was 98.5% for artificial intelligence. And the false negatives notably was 3 solid tumors, it missed 2 adenocarcinoma and 1 neuroendocrine tumor. However, there was no false positive from non-pancreatic structures. But for cystic lesions, it was found to be less sensitive. The overall detection rate was 92% for AA, but it was significantly worse compared to the US experts, with a confidence interval of 1.9 to 13.2. The accuracy dropped drastically when the cyst size was less than or equal to 15 millimeter. The US detection rate for this size was 77.8%, and the normal pancreas, US identified all patients with the normal pancreas, and there was no falsity in this. So AUS matched EUS for detecting solid pancreatic masses with a very high accuracy, despite it missed 3 solid lesions, and there was no significant difference in performance. However, for small cyst, it is still less sensitive, and with the further training of the AI model, and this may help to improve the AI's accuracy and maybe be an adjunct in for the EUS expert, and may also help in the training of new EUS practitioners. This compares the preoperative biliary drainage with metal stents versus early surgery in patients with pancreatic cancer. It was a randomized control trial, multi-center study. In India, the center was AIJ Hyderabad. It was published in Annals of Surgical Oncology, and the year of publication was 8th April 2026. And they wanted to see whether the preoperative biliary drainage using SMs was non-inferior to in safety to patients to early surgery, to patients who are planned for early surgery without preoperative drainage. So it was a randomized control trial. There were 284 patients enrolled, and it included patients with more than 18 years with distal biliary obstruction from resectable pancreatic cancer or distal cholangiocarcinoma or periampullary cancer. The proximal end of the lesion should be 2 centimeter from the hilum, and bilirubin of more than equal to 5.8 milligram per deciliter, and curative surgery was planned within 4 weeks. So 144 patients underwent preoperative biliary drainage by ERCP, and 140 patients underwent early surgery. Coming to next. And in the preoperative biliary drainage, the SIMS was inserted, and after jaundice resolution, and within 4 weeks of stenting, that surgery was planned. So the primary outcome which was evaluated was proportion of patients more than equal to 1 severe adverse events within 120 days after randomization. A secondary outcome was technical success and complications of ERCP, rate of surgery and curative intent resection, 120-day all-cause mortality, and surgical complications including subgroup analysis of patients with more than 14.6 milligram per deciliter. A time period was from 11 February 2013 to August 2021, and a follow-up up to 120 days after randomization or 30 days after surgery, or whichever is later, maximum up to 150 days post-randomization. So the so in the primary outcome, there were primary analysis among the 144 patients, 138 underwent ERCP in group A. In group B, 136 patients of the 140 selected went early surgery. There were about 29% adverse events and 26.5 observed events. The difference was 2.5%, and again the upper side at 95% confidence interval was 11.7, and the upper the value they consider was non-inferiority was 15%, so it was less than this 15%. So they preoperative biliary drainage was considered non-inferior to earlier surgery in terms of adverse events and safety. And sorry, one thing, that's all. Okay, and other things were all statistically insignificant. Both had a similar 120-day all-cause mortality, surgical complications, and overall complications. And the trial showed that preoperative biliary drainage using metal stent is not less safe than early surgery for patients with resectable pancreatic or periampullary or tumor with obstructive jaundice. The overall safety complications and 120-day mortality were similar between the two strategies. It can be considered when patients have logistic reasons to delay the procedure or for the other reasons. Now this is a systematic review and meta-analysis evaluating the role of N-acetylcysteine for post-ERC pancreatitis prophylaxis. It was published in Indian Journal of Gastroenterology in 17 January 2026, and the center involved in our was Sanjay Gandhi SGPJ, Lucknow. The primary aim was to determine if prophylactic NAC reduces the incidence of post-ERC pancreatitis and incidence of severe post-ERC pancreatitis. The rationale they thought was the oxidative stress and free radicals which are seen early in PEP could be one of the could be the main driver of the pancreatitis, and the NAC being a free radical scavenger was hypothesis to prophylactically reduce this risk. It was a systematic review meta-analysis, and a population was patient undergoing ERCP including standard and high risk groups. And the interventions actually for this study they delineated 5 RCTs, 1 multi-center and 4 single center RCTs, and all of them had different doses and protocols for N-acetylcysteine. 3 centers gave only oral N-acetylcysteine of 1200 mg 24 hours before procedure, and 1 center gave oral along with post-procedure IV N-acetylcysteine. Another center gave only weight-based N-acetylcysteine of decreasing dosages. So there is a heterogeneity in the population as well as a heterogeneity in the intervention, and it was compared to the placebo group without no NAC and not the standard medical group. The outcomes was measured as primary incidence of incidence and severity of post-exposure pancreatitis. The timeline they took studies from up to May 30, 2025, and the earliest study was from 2023. So at the end of the study, what they have told is the relative risk of post-exposure pancreatitis was not NAC was not significantly reducing either the incidence or the severity of pancreatitis, post-ERCP pancreatitis. Yes, thank you. That's all.
I have some 3 questions.
Yes, sir.
So in a patient who has operable pancreatic malignancy or periampullary carcinoma, I think going for a metallic stenting to delay the surgery will give a wrong signal to the patient if they want to delay the surgery for logistic reasons. I think we should still push the patient for surgery if they're operable rather than going for an additional procedure with ERCP. That's again going to cost 2 lakhs for the patient. So as long as it's operable, surgery should be the first modality, and just because we can relieve jaundice, we should not be placing stent. That may give a wrong signal to the patient that things are settling down and they may further delay the surgery. Second, there was one comparison between cholangioscopy. See here, to do cholangioscopy in a patient with non-complicated bile duct stone, most of the time you have to do a wide sphincterotomy or you have to do a CRE dilatation. That per se can increase risk of bleeding or pancreatitis. And it is an additional procedure, involves additional cost. And the risk to the patient is much higher when you use cholangioscopy rather than the radiation per se, either to the patient or to the operator. I think this again gives wrong information to the postgraduates that cholangioscope should not be used just for the sake of that we have the equipment, and still conventional ERCP should be performed for patients with non-complicated stones. And doing cholangioscopy just to confirm, I think it is not required. You can do it in check cholangioscopy. When you already cleared that patient comes for, you are not very sure when before removing the stent, that time already sphincterotomy is done, that time you can do it quick cholangioscopy. And third, you showed first one study, ESWL. Yeah. How you think they are going to localize the stone in CBD for ESWL?
So by imaging ultrasound.
Yeah, how they target the stone. So for pancreatic stone, these are calcified stones, they can see under fluoroscopy. And for bile duct stones, to target the stone, as the author mentioned, how they targeted the stone?
They had a nasocystic tube for that, sir. They actually ERCP.
They first do a ERCP.
They first do ERCP, and failed ERCP only they are going for this ESWR or these things, sir. Sir?
They inject contrast on table, do fluoroscopy, see the stone and shatter the stone. And that can not damage the bile duct wall. Unlike pancreas, which has parenchyma around, CBD is something different.
It's a recognized procedure only. You cannot see the stone and see just like a pancreatic stone. So you have to do a nasobiliary drainage tube and then inject contrast. And that's how the stone is visible during ESWL. It is very commonly done in Asian institutes. If there is a multiple stone, they do it.
But the point is, he has also included complicated, strictures above a stone also in this category. So if you are planning for an ESWL, what I feel is like, spyglass will give a good option of evaluation of a stricture. It's not about only blasting the stone. So I don't think at present, since they have a high-end ESWL machine, probably they use it for everything. We don't, in Chennai, we don't have a high-end ESWL. Probably the comparison itself, it's like, cannot be justified. And
spyglass with vessel forceps rather than putting an isocystic tube, taking the patient again, give a trial of ERCP again, what if it fails? I think all these studies are people who have extra facility, they're just going, they can do that.
And second, regarding the point of biliary stents and operable periampullary carcinoma, they've included the patients with bilirubin of 5.8. Probably if they increase it to 15 or something, pre-operative biliary drainage is indicated. Probably I like to have an opinion of Dr. Ravi sir. In our experience, whenever we put a plastic stent, patient comes with cholangitis in case of periampullary carcinoma. So we usually prefer a small, fully covered metal stent if the surgeons ask for a pre-operative biliary drainage. Your take on it, sir?
Yeah, for malignant strictures, generally I don't use a plastic stent. I always use a metal stent nowadays. So the cholangitis doesn't happen in stone, but most of the time it happens in tumors.
I just fail to understand how a study can be both systematic review and meta-analysis.
No, you can actually have a systematic review and a meta-analysis if you have the data as well. If you have the original data which you get back from the authors. Yeah. So the meta-analysis depends on the availability of individual point data. You can do a systematic review as well. I mean, it says that you look at all of that, put it all together, and then you do the meta. It's potentially, yes, it's possible.
One general comment about Kiran. The topic is recent publication from the Indian literature. How suddenly Shyam Radharaj came in. So basically from the Indian literature, Indian studies. So how it you classify is what are the journals you underwent, what are the diseases you looked into. That will be easier to understand the common audience. So etiopathogenesis of the pancreatitis like that. If you classify these are the diseases I went through the literature, these are the journals I scanned, and these are the most possible journals I impressed or I want to share with you. So that's how this has to be presented. Because not like randomly, suddenly stone disease, suddenly pancreatitis. It is not a way to present that. You present the way that these are the diseases I am interested in, these are the journals I scanned in, these are the important articles I am going to discuss. That's how it should be done.
Thank you, Dr. Kiran. We'll move on to the next session, sir. Thank you.
Graduate session, many unanswered questions, but I think that is what the real life is about. So I think it's good to have some inputs from all the senior persons here and how to proceed with some difficult clinical problems. So moving on to the second part, brief secretary's report. So the TNSG HCC study has been the data has been completed. The data collection is completed. Now it is in the phase of data compilation and analysis. I would request all centers who have enrolled, who have already collected the data, to kindly share with Professor Sumati for further analysis. The next proposed TNSG research project is about the GRD study. I think we recently had a Zoom meeting, and still the details are being, needs to be fine-tuned. Dr. Ilavasi is taking the lead. I think she will come back again with some more modifications as has been suggested. I think she will come back in the next month. So last month, thanks all members who have participated. We had the inauguration of the CCFI Tamil Nadu State Chapter, the wonderful meeting where more about 170 participants attended, and all the national members were also very happy with the turnout on that day. So I request all the new academic trainees who have enrolled in Tamil Nadu to become a student member of the team at TNISG. I see that only about 45 members have enrolled as student members. I request the rest to do in the coming month. Forthcoming meetings, Endocon is on from 28th to 30th August at New Delhi. The ISG main meeting is clubbed with the World Congress of Gastroenterology. So it will be on 30th September to 3rd October 2026 at New Delhi. And the midterm meeting is after the ISG meeting. This will be on 17th or 18th of October at Madurai. So please mark your dates. And ISG specifically requested that we have active participation from all the state chapters. So the abstract submission cutoff date is on 31st of May. The early bird registration is extended till 15th of May. So I request all the members to kindly register and also submit their abstract before the cutoff date. And interestingly, there's already an outline of the program which has come in. On the third day, we have on the INSL session, I think we have Dr. N. Madana Gopal Sureshan, which has already been included. I think this was for long been requested. I think this time around they have included in the ISG. So on the third day, it will be on 2nd October in Hall A from 11:45 to 12. The orator's name is, probably the final program schedule is not out, but this is the outline which I have seen there. And I'll request all to kindly scan the QR code on the desk and fill up your attendance form. And now it's a wonderful time for us to again celebrate that we have about 5th our journal, Gastroenterology, Hepatology, Endoscopy Practice, which has come up for the 5 years, 5th year anniversary celebration. I would request our editor, Dr. B.S. Ramakrishna, to also come in place. I'll also request Dr. K.R. Palaniswamy sir, Dr. Obal, our CEO, and Dr. Ravi, our president, to also come around, and Dr. Jayanti to kindly come forward and cut the cake for the same, please. Thank you, sir. Yeah, I'll request editor to give us comments on how to move forward, please. Thanks.
Yeah, so as you know, we have completed 5 years. This is the kind of distribution of articles that we have in that. And I'm showing this because I think I'm actually soliciting your help in changing the composition of the articles that we have. Most of the ones that we have are case reports. I guess it's because people find that most other journals have closed their doors or closed the journals to case reports. So we are happy to publish case reports, but we need original articles or reviews. And reviews are fine. So our publishers looked at whether we can go in for indexation. And there is a problem. The problem is that we need to publish a minimum of 30 original articles or reviews per year. Now, we are publishing on time, we are publishing on schedule, the editorial policies are there. They have suggested that we should change the composition of the editorial board and have people who represent other areas of the world as well. And that editorial board members should not be publishing in GHAM. So consciously we have removed some people from the editorial board because we hope that they will publish and keep this thing going. So my request is that all of you, particularly the students, submit reviews and original articles. See, at least the DNB students, the DRNB students do thesis, they write reviews of the literature. None of it gets published. I mean, each of these reviews of literature can be published in the journal as a review of that subject. And I have been speaking to Dr. KRP, who is actually this is the Tamil Nadu Gastroenterologist Trust, is the owner of the journal, whether we can have a writer, a professional writer, to help with writing services for those people. And I'd encourage all HODs to encourage their students to submit the reviews of literature. And then the article should be formatted properly. And the other thing that I need is that reviewers should be prompt and that they should be positive. Don't point out the negative side of the thing. It's okay, there are all negative sides. We're here to encourage people to publish. We're here to encourage the culture that people should be publishing in this journal. And we are doing this importantly without asking for any fees. I mean, unlike predatory journals which are there around the world, there is no publication fee, and that's something that is unique to this journal. So our most cited papers were this, the management of rodenticide poisoning, low volume plex, perspective on gut health, which was actually a basic science paper from Bhubaneswar, urine trypsinogen 2 in predicting pancreatitis or post-ERCP pancreatitis, and safe sedation practices in ALF. And so these are some of the performance indicators. We've had a lot of users looking at this. There's 17,000 full text views, number of logins, and this is the map of the thing. Mostly obviously hits are from India, some from the US, and also scattered from African countries and Europe. And the total article views are like this. You can see that these things are labeled there. And we had, when Ubal was there, we had these review of the Indian literature which was done extensively, and I think many of them were published. In fact, you can see that some of these are widely looked at. I mean, maybe not cited yet, but at least people are looking at them. So just a request again, please submit reviews and original articles. Please encourage your students, and we will consider providing editorial services. Thank you.
Thank you, sir. I think now we will move on to the second session, that's the CME part. I'll request the chairpersons, Dr. Murugan and Dr. Basmani, to kindly come over and carry out the proceedings, please.
The first talk is on GI disorders in adolescents. It's a very important topic. Now, the transition from the pediatric to the adult gastroenterologist is an important area that needs to be addressed. For this, we have none other than Dr. Nirmala, consultant, Department of Pediatric Gastroenterology at ASIC Medical College. Welcome, Nirmala.
Respected chairpersons, dear teachers and friends. Now all of us know, I think all of you are aware that the pediatric age group goes up to 18 years now, and young adults up to 26 years, and then maybe pediatric age can get extended into even beyond this after some time. Okay, and all of us have been transferring all these years children from pediatric age group into adult side. It has been happening for years. We have done for so many years, but are we doing it the right way? We don't know. But now, lot of talk about how the transition has to be and how it has to be done. Lot of talk is going on, especially in the European countries and to a certain extent in the North American countries also. So I've just, though not a personal experience, I just tried to get whatever available in literature. So we know that there is now more and more children are surviving into, children as well as adolescents survive into adulthood nowadays, and that because of this there is a growing adolescent as well as young adult population, and because most of the time when you transfer them to the adult side, most of them there'll be a loss to follow up, either because they will not like the new environment or they don't want to continue to something, there'll be loss of follow up, and this loss of follow up and medication non-adherence can lead to disease exacerbation and also increasing mortality and morbidity. So this transition period is a very, very critical and high risk phase which has to be addressed in a very methodical way. So transition should be a structured and developmental process, and it should not be a mere like you transfer accounts from one person to other. It should not be like that. It should be a structured and developmental process. By definition, transition is a purposeful planned movement of adolescents and young adults with chronic physical and medical conditions from a child-centered to an adult-centered healthcare system. This is the definition given by the literature. So adolescent, we know that it's a very, very unique group. Maximum growth occurs during this period. The growth spurt, they increase in the height as well as in the weight, and also even the neurodevelopment also occurs. But most important of the development which occurs during adolescence is the psychosocial maturation. That is, you are actually entering from a childhood phase to an adulthood phase. It's very, very important that this is a period of priming of these children to go to reach adulthood. So during this period, though there is an ongoing brain maturation, but the child has not fully developed the executive function. He is not able to carry out the work as the brain dictates. And we have all of us are aware that there is a much more risk-taking behavior at this age group. They go into all adventure sports, they go into car racing, bike racing, and they also get into all addictive behavior like substance abuse. Everything it's more common in this period, and this is a period when they don't listen to parents. The parental intuition totally goes off, and they'll be more attached to their friends, and the peer influence they're given more important to peer words and peer influence than the parental influence. So in other words, we can say that they are trying to be on their own. So what are the clinical implications of these adolescent behavior is that there will be poor adherence. This poor adherence is not like in other cases, like it's not a non-compliance allowed. It is more of a developmental delay. This age group generally tend to revolt. They don't want to do. They don't want to listen to anybody. They want to do everything on their own. So that is the reason for the poor adherence, rather than a non-compliance like in any other adult case. So that is the reason we have to have a graded responsibility transfer from the pediatric to the adult side. And this adolescent group is not very small as we all think. It is 1 in 6 according to WHO. 1 in 6 in the world we belong to the age of 10 to 19 years. And as I already mentioned, it's a unique group and it's also the formative years. So, thanks to the improved medical treatment and availability of new drugs like nitisinone and other drugs which are used for metabolic disorders in childhood, if the children are reaching into adulthood. In addition, the most important surgical technique which has modified all these things is the liver transplantation. Because of the liver transplantation, many children are now reaching adulthood. So because of this large proportion reaching adulthood, we have to formulate some steps to transition from the pediatric to adulthood. This transition, according to literature, most of the literature states that this transition typically should be between 16 and 21 years. Because that is the age group ideal, because so that we start priming them, and then so that by 16 to 21 years you complete the process so that they can reach adulthood. Mostly the children with very complex disease like in a case of IBD, or children with multiple disease like multi-system disorders, and children with already have a psychological comorbid or psychological overlay, and those with a low health literacy are the high risk groups which may find difficult in this transition. So this is a UK study. There is a UK study where they have predicted that they extrapolated and estimated the prevalence of chronic liver disease in children, and how many of them may go into adulthood in per year. According to this study, in IBD, though there's around 7,000 cases per year, and about 10,000 of them go into adulthood. Similarly, in CLD, between 11 and 15 years there will be around 1,500, and 16 and 17 years there will be around 624, and around 600 may go into adult every year, and celiac disease around 600 per year may reach adulthood. And functional disorders, although there is no specific data about how many of them will go, there are approximately around 10% of the population will have this functional GI disorders. So what are the disorders which will definitely require transition? As we all know, this is with chronic diseases. What are the chronic diseases which commonly go from the pediatric to adult cases? One is the inflammatory bowel disease, which is the most commonly studied, most commonly giving problems, and most studied model is the IBD model. As far as the chronic liver disease are concerned, autoimmune, when we were all Initially, when we are in our pediatric group, autoimmune very rare. Autoimmune hepatitis is very rare. Maybe once a year or once in 2 years only we used to find one autoimmune hepatitis. Now it is really it's become it's increasing more and more every day. Almost every month we are able to see one autoimmune hepatitis in children, and all these children with the availability of all these immunosuppressants will reach adulthood. So definitely we will have to transfer them to the adult care. And similarly, Wilson is always, we have always had a problem with Wilson's disease. We have been transferring them even from those days. And a big chunk is this post-transplant children. Now they have many. We know that many of them are undergoing, you know that RELA does 100 pediatric liver transplants per year. So most of them will go into adult care. So you know that the number of cases going to adults is increasing day by day. And those days when we were practicing, the most commonly which we used to transfer was only the EHPO with bleeder. These were the only cases we used to transfer them into adult side. Most of the chronic liver diseases may not reach adulthood, but now more and more other diseases also started going into adult care. Functional DA disorder, we know that functional DA disorder in children will definitely go into adulthood. So definitely there will be a transfer. And nutritional disorders, especially celiac, it's not very common in our setup, but still there is a lot of challenges with regards to diet adherence. So what we have to understand is each and every disease has got different clinical presentation, so they will have a unique transition vulnerabilities, and then there will be a lot of gaps. So what are the barriers for the effective transition? It can be at the level of the patient, or the family level, the provider level, or even a system level. As far as the patient level, there is limited disease understanding. This partly belongs to us. It's because of us. Whenever we talk to the parent or caregiver about the disease, we generally don't include the children or the person who's suffering from them, because they are all small, we think. But now we should understand that even they should be included in the counseling sessions. They should also know what they should know about the disease and how to go about it. And we have seen that all these days they have been dependent on the caregivers. Suddenly getting out of the care is very difficult for the patient, and in addition to that, the adolescents already have all these mental health issues. As far as the family is concerned, our society, we know that it's an overprotective society. We always protect them as long as they are children. We protect them. Once they become adult, we want them to be responsible. How to bridge this? Most of the time we don't know. So this overprotectiveness, because of overprotectiveness, that will be difficult to relinquish. That is, we will not be able to let them go. So that is a problem in our set, especially in our setup. As far as the provider level, we know that as far as in our country, there is lack of training in transition care. We don't even think about transition care, and we have not even, none of us, including the pediatricians or the adults, none of us have training in transition care. And also when you are planning to transfer the patient to adult, some patients we will talk to the adult physician, say that we are transferring this case, kindly take it, but most of the time we just write that go to the adult center, and we may not even communicate with the adult provider that we are going to send one patient like this. And at system level, we know there are no structure, we don't have a written protocol in India, and when the child reaches adolescence, we don't know if the insurance is going to cover them or not, and the financial issues are going to go up, because the adult, as they become the adolescent and adult, the cost is going to be higher only, and the care is not continuous, it's usually fragmented. So what could be the consequence of this poor transition? All of us know that one study has shown that there is increase, almost 20% increase in the number of hospitalization in the first 2 years after the transfer into adult care. And similarly, they have found that there is increased disease relapse, basically because non-adherence to treatment or loss to follow-up. Then similarly, because there is a non-adherence and there is increased exacerbation, there will be emergency care dependent on these children, and all these things together with the low self-esteem and the decreased scholastic performance, they will definitely have a reduced quality of life. This is particularly documented in IBD cohorts. So for the first step when you start to transition is that assess if the child is ready for transition or not. This is called transition readiness. What are the domains you have to assess under this are the knowledge of the disease, medication management, find out if they will be able to navigate the healthcare, just go to different places and will be able to speak for themselves, self-advocacy. There are many tools, internationally there are many tools. The most common and most popular tool is the TRACK, that is Transition Readiness Assessment Questionnaire. This is the most commonly used. It's common for all chronic disorders, but in addition there are also some disease-specific checklists are also available, and we all know that age is not equal to readiness. This is the TRACK questionnaire. It may be not very clear. The TRACK questionnaire actually addresses the following issues: managing medication, appointment keeping, tracking health issues, managing daily activities, and talking with providers. Each are given number from 1 to 5. And this has been validated well by many studies. One study has shown that transition readiness is defined as low, moderate, adequate or excellent based on the track percentile scores. If they are less than 25 or 25 to 50th centile, 50th to 90th or more than 90th, anything above 4, that is beyond 50th centile has been considered to be adequate. So this is with respect to IBD alone, so a separate checklist for IBD alone. So once you start, once you assess that the child has been ready for the transition, then you have to how to go about the transition. The first, you should initiate early. Begin as early as 12 to 4. Though we already mentioned that 16 to 21 years the right age, but you have to start early. To initiation, we start early. In our OP, we always used to, whenever the child reaches, we only up to 12 we used to see in ISH. So whenever the child reaches 10 or 11, you always say that in 1 or 2 years we'll be sending you, so better be prepared, you have to go there. And similarly, you get to prepare them that they have to go out after a few more years. So initiate as early as possible. And even this, once you starting the transition care procedure also, it should be stepwise. Each and every way, give them one responsibility. Not everything at the same time. Give them one responsibility so that they will be able to undertake each and every responsibility in an effective way. And it should be always for any case it should be patient centered. That is, it should be depend upon the cognitive and emotional maturity of each and every child. This is not same for everyone. As already said, age is not equal to readiness. Similarly, age is not equal to maturity, emotional maturity. So everyone will be different. So depending on the patient's maturity, we have to talk to them. And the most important part is the multidisciplinary care. This multidisciplinary care of transition unit should consist of not necessarily GA, some a physician or GA specialist if possible, a nurse, a psychologist and a dietitian. The most important person in this whole thing is the nurse. The nurse is the transition coordinator. He will be coordinating everything in the transition. That's why the most important part of the transition team is the transition nurse, or otherwise called as transition coordinator. So there are various models that have been adopted by different systems. This is what they usually done, direct transfer. What we used to do in our OP, when you don't like the patient, they have been giving lot of troubles, then refer to RGGH for further management and then transfer them to RGGH. That's what we used to do. If the patient has been very good and very obedient, that is the direct transfer. That's got the poorest outcome. And next moment sequence, this I have done. This we have tried to, most of the patients we try to do this. We start preparing them earlier. Tell them that by 10 years that they have to go. Then ask when they reach 12 years, we ask them at least go to RGGH at least once. Register yourself in the OP there. Start getting drugs, so they get the drugs there also and get the drugs here also, and combine for some more times. And then once you feel that they are comfortable in that place, then you can transfer them to the. That's for some patients we'll do this. And the best practice model is the joint clinic model, which is not. I don't know if any other hospital is practicing that. We have not done it. That is the best model. None of the I think our setup we are practicing that, where both pediatric and adult providers are sitting together and then conducting assessing the patient. This as obviously will build up a lot of trust, and then the patient will continue the treatment also. So this are the what should the program contain means. You should have always, like any other policy, you should have a written policy, transitional, because otherwise you'll miss out certain items. So always whatever you want to tell, whatever you are going to do, always write down. So we have a written policy. Possible if we can make it the policy, is ideal. Then as I already mentioned, should be individualized depending on the patient's maturity, should be individualized. And make sure that always such when you are attempting a transition, always make sure that they have a portable medical summary. That is, the summary should be either in you can have laminate that and give it to the child, or you can have it in the like WhatsApp or in a laptop or something. You can have it. And then nowadays for education models are available for every other disease, for everything, for counseling, everything is available. So we can make education modules, and whenever we are planning a transition, I can play them and ask the child to go through it. And you should also have a definite transfer time. As I mentioned, you have to start by 12 to 14 and you have to finish by 21. But anyway, you have to define that for 2 years I will prepare them. For 1 year I will ask them. I'll assess the readiness. For 1 year I'll go through the process, and 1 year I'll follow up, something like that. You have definite transfer time. Only then we'll complete the process appropriately. And most important part is the post-transfer follow-up. Just leaving them alone and then just forget them, that then it's not going to work out at all. You have to follow them up, see them at least for 6 months, see them they are going or not, and then get feedback from them. Only then they will continue the care in the adult setup. So this is the transition pathway which the UK model, the United States has adopted, where they find out one if this child is does have a chronic disorder which requires transition or not. They first find out. Once they find out that the child definitely has a disease which requires transition, then they assess the readiness. Once they feel that the child is ready for the transition, then they set up the clinic. That is, they identify the clinic, they set up the team, they ask the coordinator, who's the staff, who's the nurse, who's supposed to see everything, arrange for the joint clinic and everything. She's supposed to arrange all those things and then go for the transition process. Once the transition process is completed, we are able to do give all the instructions to the child and the caregiver. Then finally go for a follow-up, where I already mentioned 6 months you have to follow them. Anything problem you think during the 6 months, you ask them to bring back and again examined by the multidisciplinary team, and then again go ahead with the process. So this is a transition. This is adopted by UK. It seems to be a very good model. Everyone can adopt this. So according to this study, assessment of transition readiness, individualization, disease specific education programs, flexibility in timing, and named transition coordinators are considered to be the 5 most important components for successful transition. And this successful transition can vary somewhere between 12 to 36 months depending upon the individual child or adolescent. So this is from the position statement by the Italian group, where they have studied the character of transition in various groups like IBD, celiac disease, and chronic liver disease. Usually, most of the cases they want to start it around 16, or some in case of CLD 16 to 18 years, and duration will be somewhere range between 6 to 12 months. And throughout the transition process, the specialist should either stay in direct contact or at least through the other ways like web calls or something. They should stay in contact with the patient, and then at least 1 to 2 visits should be there. Combined visits should be there. Some cases like CL it may even go up to 4. And location of the visit usually be between the adult, as it mentioned, it will be the one time in the adult, one time in the pediatric, something like that, or can have a transitional clinic. And then you should better to have the services in the secondary or tertiary care level, so that will be better. All the required things will be available in the secondary or tertiary care centers. And in adolescents, there is a very high prevalence of psychiatric illnesses like anxiety, depression, and adjustment disorders. We are hearing so many things in the newspaper also. So because of this and the mental issues, there will be a lot of problems like adherence, and also the outcomes also will depend upon the adherence. So in all the patients who are going for transition, you have to have a routine psychological screening before starting the transition process. And family, I already mentioned, family is one of the important, which prevents smooth transition, because ours is parent-led rather than a patient. So parent-led as a community, where so shift from a parent-led to patient-led is very, very difficult. This family dynamics has to be taken care of before you attempt a transition. The problem is that most of them, they think that no one else in the world will look after the child better than the parents. That's what, or the caregiver. That's what they always think. That's why they never let them go. This is a problem with the family dynamics. So how to overcome this? Actually, you can give a parallel education to the caregivers as when you start educating the patient, so that this will cause gradual parental disengagement and can cause a smooth running of the transition clinic. So what are the challenges of the health system? The major challenge of the health system is that you have to move from a pediatric to adult care. Pediatric is a multidisciplinary care, family-centered care, holistic care, collaborative care, and developmental care. Whereas adult is monodisciplinary, there is predominantly medical, patient-centered, autonomous, and consistent. So this transfer is going to be very, very difficult with respect to health system. Similarly, we know that most of the adult care providers are not trained in pediatric onset diseases, and many times I have seen that they are also scared to see pediatric cases. They are scared to see always. They don't want to see patients who are coming from the pediatric side. So this also makes the system a little complicated. So what are the strategies you can adopt to improve? It's all come in the previous slides also. How to improve the transition? One is the clinical strategies could be one. They should have you can have transition clinics where both the adult and the pediatric care provider is going to sit, and you can have the readiness assessment, which can be done by a questionnaire method, and you can have a written and standardized protocol. Behavioral, you should have a motivational interviewing, self-management training before starting this. And nowadays with the media, you can use digital tools like apps for reminders and telemedicine for follow-up. So how is technology going to be useful? There are many like other disorders, web-based and mobile technology have been used even in the transition process. As we all know, we'll be able to with this apps we can individualize the treatment. You can maintain anonymity, then you can have a rapid access, it will be low cost, easily available, but you can also cross all the geographical border to give the messages. One such is that this MD2ME is one such app which has been tested in a number of chronic diseases including IBD. This is a technology based where there is a communication between the healthcare team and the patients. Only thing it is able to improve the health related self-efficacy, disease management tasks and patient initiated communication, but there is no beneficial impact with reference to quality of life measures, functional performance or disease status for obvious reasons. So what is special, especially in our country, what is special consideration? We have a lot of socio-economic barriers, disparities and financial constraints. Most of them, even normal treatment they cannot undergo, but it's a complicated disease, very difficult to treat outside, and so there will be a discontinuity in the treatment. Similarly, cultural influences, lot of we have to actually when you plan anything, you have to go according to the local culture, otherwise it will be a failure model. And then health literacy edition, we know it varies very much in our country, like Kerala will be 100% literacy, whereas UP may not have that much of literacy, so there will be lot of variation in the health literacy also. So taking all these things into consideration, we have to form a model for our country, and this actually I have put as limited, but I don't think there is any structured transition clinic in our country as far as I know, so better to have structured clinics at least in the future. So what are the future directions? So we have to have a formal transition guidelines and transition clinics, and integrate the digital health and telemedicine in the transition process also, and more and more research which will be outcome oriented on transition, and training program for adult gastroenterologists to manage pediatric patients. So am I concluding the talk with transition is definitely a high risk, but definitely we can manage, which definitely is a modifiable phase. If you have, where you have a will, there is a way. And when you have a structured, multidisciplinary and patient-centered care, then there will be improvement definitely in the adherence, disease control as well as quality of life. And final takeaway should be successful transition is never intentional. It should always be intentional and not incidental. Thank you.
That was really a nice disposition. I think it's a topic of the need of the hour, I think. Dr. Nirmala has really exposed so many lacunae. No, as adult gastroenterology, we are scared to see pediatric. That's true. We have no concept of transition. Age is not, prepared. No, human adolescents, young people are like a Benz car. No, by 18 or 21, the body is fully mature, but the brain is still maturing, and it's like giving a brand new Benz car to a young driver. Learning driver. They will go and damage the car. Now, without damage, no adolescence. But how they learn from damage, especially this kind of post-traumatic stress disorder and adjustment disorder patients, we lack knowledge, skills. I think Nirmala should think about putting a module, training us into.
As I went through all this literature, I thought I should do it
vigorously. I have done a transition clinic while I was in UK, cystic fibrosis, chronic liver disease. There are structured clinics. Even there, getting a pediatrician and adult gastroenterologist is costly. The money and the time constraints. So we have to schedule far ahead, to get two consultants. And if it is US and here, will they pay two fees for both the consultants, or we have to split the consultation fee by 50-50 in private sector? So many things. I think it's a very nice topic. Next few minutes we can open the topic to the forum.
I can ask you, in India many people do DCH and then do adult gastro. So you can do both, no? Why do you need a transition?
Actually, that's why I put the last slide. I moved now
from a good way to go forward?
Pediatric to adult. I have moved now.
But is it a good way to go forward, or should people like you concentrate one or the other?
Actually, when all of us were, when we all did adult DM only, sir. Adult DM, and then we moved into pediatrics. So we had a good knowledge. But nowadays these people are doing only pediatric DM. That is a lacunae for them, sir. That is definitely a lacunae for them to get into.
It's not just the provider. No, she said it's a multidisciplinary. The way we look at the patient, but they may learn adult gastroenterology, but do they still have this setup? Specialist nurse, psychological assessment, access to resources, and providing
in a government
holistic
setup, I
care.
think it'd be easier, sir. Because we get all the specialists together, we can arrange clinic. But in a private, as you said, you have to pay fees for each and every person.
But India,
Very
our
difficult.
problem is otherwise. How many of you have seen 35, 40-year-old patient coming with the parents? No.
We have seen.
Yeah,
we have
they
seen.
come and hover like hawks and then give all the histories, sari smiling. So we have very prolonged childhood in familial hierarchy in India.
We used to have a patient, that mother will come with the child and the mother will have a list, that Mamiar has given one list. Ask all these things to the doctor. So every time she'll come, she'll ask everything and then tick and then go.
So,
Otherwise my mother-in-law will scold me.
So all of you be prepared for prolonged childhood of your children. No, I left my home at 17 and never returned. My son is 27, he has not yet left. No, they really enjoy prolonged childhood. No, they really stay at home until 20, 25, 30.
That much of comfort we are giving, sir.
Yeah.
I think we should not give so much.
But that's not a isolated phenomenon. We should prepare ourselves to treat them as children even in their late 20s.
I thank TNISG, especially Sheshadri, for giving me the topic. Because of him only I had to go through so many.
Very nice, actually, engaging actually throughout. I wish this topic could be made a chapter in our own gastroenterology. Once make it a chapter, we have to read, we have to imbibe, we have to buy heart.
Yes.
Then it becomes imprinted and Pasmaratani Mari Padalam. So many talks, but the chapter, the writing and thing, that will probably we can put a one small thing to the singer. We can add this. This is an important thing. We are seeing a lot of Crohn's and liver disease thanks to transplant. They are moving,
all of them moving
and all.
into adults.
And we are doing all the functional GI disorders. That Professor Man has not come, motion man has not come. So that okay. That so this thing is a transition. Is also transition for us from move to one place to another. So always what Basu said is correct. We never left the house. I never left the house. Still I am in the house. So it's nice for me.
You are a unique person.
And all of you will agree, the slides were fantastic. Postgraduates, no, there were no more than 6 lines in a slide, no more than 6 words in any sentence. And it was clear with little cartoons and things
Thank
like
you.
that. Fantastic.
Thank you. We'll move on to the next topic, update on management of PBC. I suggested this topic to Swati. PBC, some new developments have happened and promise of more new drugs to come to treat PBC. So when we look at PBC, we look at 2 things. One is we try to treat the quality of life. They have tremendous pruritus, which is the main symptom of PBC, and transplant is indicated only for pruritus. So it can be as bad as that. Second will be fatigue. That's also quite exhausting and it completely takes away the ability to live a normal life for these patients. Since I had the opportunity to work in UK, we have seen a lot of PBC patients, but not that much in India. And they come to you for the whole duration, 20, 30 years, they'll be in the same clinic. Second aim of treatment in PBC is to prolong the clinical duration before transplant or other complications, to prevent disease progression by achieving biochemical improvement or biochemical remission. So addressing these concerns and with the drug development, 2-3 new drugs have come in the market in the last 2-3 years. So hopefully Swati will cover all of them and any other new drugs that are going to come.
Yes, sir. Thank you for having me here. So good evening to all. So I think the update on PBC management, I think this topic is given at a right time. I think ever since 2023, we've got 2-3 new drugs into the market. So I'll just be taking through all of that. So just a little bit about the disease. So it's called primary biliary cholangitis. It's a chronic cholestatic disease of probable autoimmune origin, and there is a destructive lymphocytic cholangitis of the biliary epithelial cells. There is a female predominance in the incidence. It's almost 10:1, and the age of presentation could be around the 4th decade. So the clinical features are fatigue, like Sir was talking about, intense pruritus and jaundice. There are some extrahepatic clinical features like dry eye syndrome, that's called as the Sika syndrome, thyroid dysfunction, especially autoimmune thyroiditis, and systemic sclerosis. So in the biochemistry, we typically look at the liver function tests where there is an elevated serum alkaline phosphatase, maybe a gamma GT elevation. If the disease is very advanced, there could be bilirubin elevation also with transaminitis. And the typical autoimmune markers that we see are the AMA and the PDC-E2 subunit and the anti-GP 210 and anti-SP 100, which are positive even in AMA negative serology. So the incidence is very rare in India. When we take it, there was a study conducted between 2016 to 2020, which was around 2,500 CLD patients, and in that there were only 14 cases of PBC and 18 cases of overlap syndrome. And in India it is almost 0.5%, that is the literature that we looked at. So most of them come to us and with symptoms of liver cirrhosis, and when we go back and do the transplant workup, we find the autoimmune markers positive, and by then it is very late for us to do anything for them. So this is the pathophysiology, where there is a healthy individual with a genetic predisposition, could have been exposed to some environmental triggers with the immune dysregulation, which causes bile acids metabolism dysregulation, and there is a disruption in the biliary bicarbonate umbrella, which causes the cholangitis, non-suppurative cholangitis. So as per the EASL guidelines, the diagnostic criteria is a persistent, that is more than 6 months, elevation in the alkaline phosphatase levels with a normal biliary tract on an imaging. And there is an AMA positive titer of more than 1:40 on immunofluorescence with a positive PBC specific ANA, that is anti-SP 100 and anti-GP 210. There could be we could also include a histological evidence of non-suppurative cholangitis in these patients. So any 3 out of the 4 could qualify for a diagnosis of PBC. So this diagram shows all the pathogenic abnormalities and the target areas for therapies in the patient. So I'm not able, yeah. So this is the bile salt export pump abnormality through the FXR receptor. This causes, there is a increased inflammatory cytokine TGF beta, there is inflammation across causing bacterial translocation, there is a dysregulated metabolism, inflammation, and there is also reactive oxygen species. So these are the predominant therapeutic targets for the drugs. So I will be going into each of it in detail. So this is the timeline of the drug emergence. So in the 1990s to 2000s, there was UDCA. That was the standard of care. It had very good response, but the non-responders were very significant, at least 30 to 40%. Then in 2010s, there was obeticholic acid, which came as a major breakthrough, and that was the start of targeted therapies, which targeted the FXR receptors. Going decade later, in 2010s to 2020s, there was some buzz about NOX inhibitors, IBAT inhibitors, but nothing really. They were all in the trial phases. And in the last 3 to 4 years, from July 2023, we have the PPAR agonists, which are right now showing very promising results. So some of the medications which are still in the phase 2 and phase 3 trials are seladelpar, elafibranor, and saroglitazar. Many of us would be familiar with the saroglitazar for MASH, but this is also being now considered for the as an antifibrotic agent in PBC as well. So the landmark trials, which when I went through, I have put it here are the French and Mayo trial was for the UDCA. Both of them showed good ALP reduction with improved survival. The obeticholic acid, the landmark trial is the POISE trial, which also showed very similar ALP reduction in UDCA non-responders. And fibrates are up and coming now, where there's a Bezourso trial and the FENFIT trial, where they have shown complete biochemical response and ALP reduction in the initial stages. And the PPAR agonists, that is the elative trial for the elafibranor and the enhanced trial for the seladelpar, which have showed very good results as well. So before we start on any kind of therapy, what do we assess? How do we assess the risk? So there is a baseline biochemical, clinical and clinical parameters which we should be doing. The parameters are the bile acids, white cell count and the LFT. Where we look at the bilirubin and the albumin and alkaline phosphatase. So this is one criteria where I came across where the parameters were measured 1 month after UDCA therapy, and when they met these criteria, that is when the ALP reduced 2.5 times, aspartate transaminase reduced, and the total bilirubin also reduced, the event-free survival rate of 64% in non-responders compared to 97% in responders. So we also assess the disease stage the liver is in, that is we see the extent of liver damage for estimating the prognosis. So we do invasive or non-invasive. I think we are all leaning more towards invasive, non-invasive hepatic to find the degree of liver fibrosis in terms of fibroscan, and a threshold of 10 kilopascals is used to define CLD. When there is and we also have to accurately stage the risk of progression, liver decompensation, etc. If there is no degree of advanced fibrosis, they have a very stable disease, then a periodic assessment every 2 to 3 years is helpful. So we also assess for comorbidities which are associated with PBCs. We all know that the autoimmune diseases come in groups sometimes. So we also screen them for autoimmune thyroiditis, Sjogren's syndrome, rheumatoid arthritis, Sika syndrome. They also have a very high risk of osteoporosis, bone fractures. So a baseline and a regular screening every 2 to 3 years with the DEXA imaging is recommended, and of course a vitamin D, calcium, phosphorus, parathyroid hormones. So they also have an 80% of these patients have hyperlipidemia, thereby increasing the cardiac risk. So these are all some of the things that we need to screen and understand about the patient before going in for the therapy. So going for the UDCA, just a little bit about the mechanism of action. So it is taken up here by the hepatocyte. It is via the NTCP and the OATP, and the conjugation happens with glycine, and through the bile salt export pump, it goes into the bile. Also, this is it increases the choleresis and the bicarbonate secretion inside the bile. So the chlorine and the bicarbonate secretion comes into the bile. So there is also it also inhibits the reactive oxygen species and the MPT, and whereby it helps for the membrane stabilization, and it protects the mitochondria as well. There is also an immune modulation where there is decreased MHC expression, decreased immune mediated injury, and thereby a decreased T cell injury. So finally it all results in a decrease in the cholestasis and an improve in the bile composition, thereby ultimately protecting the hepatocyte. So the dose which is mentioned is 13 to 15 milligrams per kg per day. It is either given as a single or better divided doses, and the benefit, like I have said, is it improves the liver biochemistry, it delays liver cirrhosis progression, thereby decreasing the complications of liver cirrhosis and increasing a transplant-free survival. So the monitoring is done by serum alkaline phosphatase and bilirubin, and a regular follow-up of liver function test with elastography is enough, and the duration is lifelong if it is tolerated. The response is usually assessed at 1 year with these parameters. Usually 25 to 40% do not respond to this. That is where the newer medications have come, and 3 to 5% have intolerance. So next is the obeticholic acid, where it acts at the FXR agonist. So what it does is it affects in the liver and in the intestine, where it downregulates the CYP enzyme, and thereby the fibroblast growth factor is stimulated, where there is it affects the lipogenesis, gluconeogenesis, and it causes liver regeneration. So previously it was approved, but as of 2024 it has been withdrawn because of a lack of benefit. So the target gene is the FGF, and it is second in line when in UDCA non-responders. They have to be excluded in decompensated liver cirrhosis, especially portal hypertension. The dose which was tried was the 10 milligram versus the 5 milligram, and the placebo versus the obeticholic acid, there was a 10% versus 47% benefit, with a 40% increase in dose dependent pruritus, which was the main cause of discontinuation. So coming to the more important drugs right now. So the PPAR, just a little bit about it. There are 3 receptors, that is alpha, beta, delta, gamma, 4 receptors, and we can see that they are present. The receptors are present in a multitude of places, starting from the liver, heart, skin, kidney, intestines, eyes, stomach, and at each point they give some kind of a benefit. So going forward, looking at the receptors on the liver, so we have the PPAR alpha in the hepatocytes, gamma in the Kupffer cells, and the delta in the hepatocytes, Kupffer cells, and cholangiocytes. So what they do in the hepatocytes, the actions are mainly the reduction of inflammation, regulate the lipid metabolism, thereby it reduces the liver fibrosis, and it regulates the bile acid metabolism. In the Kupffer cells, it reduces the inflammation and antifibrotic activity. The PPR delta causes a reduction of the inflammation, decrease of steatosis, and it protects from carcinogenesis. So we can see that it confers protection against inflammation, and it helps in antifibrotic activity as a general rule. So when we look at the main PPR agonists which are being studied are seladelpar and elafibranor. So the PPR agonists include fibrates and non-fibrates agents, and they modulate the bile acid metabolism and the immune responses. They enhance the biochemical responses, and they elevate pruritus. So they are all in the phase 2, phase 3 trials, and they have shown very good biochemical response in terms of marked reduction in the alkaline phosphatase and marked reduction in the pruritus. So combining them with other treatment modalities have shown great benefit. So this is how they act. The seladelpar acts here, where it activates the PPAR delta, where the FGF is downregulated, and then that is an enzyme which is involved in the bile acid synthesis. The elafibranor, it modulates the alpha and the delta receptors, and it regulates the lipid metabolism. So it improves the steatosis and reduces the inflammation. Thereby it improves the liver function in PBC patients. So sorry for the busy slide, but I just wanted to show the comparison. So the seladelpar, as I have already said, is both of them reduce the bile acid. While seladelpar reduces the bile acid synthesis, elafibranor increases the detoxification as well as reducing the bile acid synthesis, and there is very marked anti-inflammatory and anti-fibrotic properties in both of them. Both of them have shown around a 40% reduction in the serum alkaline phosphatase, and they have improved on the many scoring systems. They have shown that it improves the risk, reduces the risk of progression to liver disease, liver cirrhosis. They also showed marked improvement in resolving the pruritus and elafibranor in particularly has reduced because it affects the lipid metabolism, reduces the cholesterol and the triglyceride levels as well. Both of them are have shown very good safety profile as of now. There could be mild GI disturbances like nausea, diarrhea, headache, which have been noted. So going to the fibrates, which are the other kind which also activate the PPAR, they have very similar mechanisms of actions. They also have an effect on the FXR agonist, which adds on to the anti-cholestatic properties. And the key, they are mainly used as an adjunct in the UDCA non-responders, and we don't use them much here. So the adverse effects is the transient increase in the transaminitis, reversible increase in creatinine, and muscle pain like with statins. So the key trial is the Besurso trial, where the population was UDCA non-responders, where they were tried with UDCA versus a placebo. So the results were measured at 24 months, where 30% showed complete biochemical normalization versus 0 in placebo, and they reduced the liver stiffness and pruritus. So we have started all these medications. Now how do we assess? What are the different scores for the response? So over a period of time, a lot of scores have come up. The key scores which I have highlighted here are the Barcelona, Toronto, Globe and UK PBC. So the Barcelona is easy to do, the calculation is very easy, but it is less accurate. Even the Paris one has the same issue. And all these scores are studied after 1 year of treatment. Toronto is also very widely used, but the downside is that the response is studied at 2 years. So the best score of all these right now is the Globe score. So it is very accurate, it is very widely used, and the parameters used are the age, bilirubin, alkaline phosphatase, albumin and platelet count. To remember it easily, it's ABAP. And there is a formula on the internet which we can put in these and we can get a score. So this is now widely used, and a very good alternative is the UK PBC score, which is also measured at 1 year. This, in addition to being accurate, is very good at individual risk prediction. So these are, I would feel, the two best scores which we can use now. So what labs would we do to monitor the response? Like I mentioned, the key markers are the alkaline phosphatase, where a continuous elevation indicates ongoing cholestasis and inflammation, and the target reduction should be 1.5 times of the upper limit of normal. The bilirubin, if it keeps increasing, it indicates very poor liver function, and probably this patient would go for a liver failure, decompensated liver failure and a transplant. So the target is that bilirubin should get normalized. The alkaline, the transaminitis, if it is increased, favor more in terms of a AIH-PBC overlap, or that the disease is very bad. They have very worse prognosis. It's a more aggressive disease, and the predictors of mortality are albumin, platelet, INR, which would indicate the liver is probably decompensating. So we can also use a fibroscan to assess the radiological, the fibrosis of the liver. So these are some of the other, in the mid-2020s, some of the other symptom-targeted therapies. We have the IBAT inhibitors, where it is predominantly used for pruritus and probably for the better sleep. It is still in phase 3 trials as of now. And volixibat, there's very little information I could find on that. It's still in ongoing trials. Immunotherapy has been one thing that is considered because we feel it's an autoimmune disease, probably immune suppression, but it is very limited in its benefits. It's less successful, and though it is autoimmune, immune suppression would not contribute to effective therapy in this scenario. So this is a flow chart of how one should proceed. So there you can start with the UDCA. Still it holds very good in current clinical practice, 13 to 15 milligrams per day, and we can evaluate the response at 6 or 12 months. Preferably, I would preferably like to do it earlier as well, not wait till 6 months. And if there is a response, we continue the UDCA. If there is no response, we do add on. So what are the things that we can add on right now? There are newer therapeutic agents. They are still in the trials, phase 3 trials. So seladelpar and elafibranor are the probable drugs which could come in the future as an add-on therapy. Other treatments, fibrates, are still off-label right now, and obeticholic acid has not been used much. The associated symptoms is pruritus. So if there is itching and it really disrupts the lifestyle, the first line could be cholestyramine, bezafibrate if it was available. Second line, rifampicin could be tried, naltrexone or other similar opioid antagonists. Sertraline is another drug. The third line for extreme itching is plasmapheresis. Experimental therapies are there, and finally what we follow now is intractable pruritus, disrupting quality of life. We do offer liver transplant. Prevalence of the fatigue is almost 78%, which reduces the ability to do the daily activity. It affects their mental and physical capacity, and it worsens over time, sometimes even persists beyond post liver transplant. There is no drug therapy for fatigue, unfortunately. There is only education, counseling. Certain mindfulness therapies, meditation are being considered, but fatigue is a real problem. So I will end with this slide. So this is a flowchart of how to proceed when you get a patient. So initially we do the liver test, look at the symptoms, do the blood test, which includes an autoimmune panel, and then based on the blood chemistry, we can and if the autoimmune markers are positive, if they are not, then a liver biopsy may help for the diagnosis, especially what we see are to rule out the autoimmune overlap syndromes. So once the diagnosis is made of a PBC, the first line is UDCA. We monitor the response to UDCA for 3 months, and then if there is no improvement biochemically, their add-on therapies can be considered at some point in the future. But right now, if there is other signs of intractable pruritus, possible liver cirrhosis worsening, I think an early counseling for liver transplant would benefit the patient. Thank you.
Thanks, Swati. I think it's a nice review of PBC. Just to add to what you said, elafibranor and seladelpar have been approved by FDA now in the last few months, and also the linerixibat. So there are 3 new drugs that is available officially to be used. And I think seladelpar is also available in India, like through special permission.
Yes, I think through certain pharmaceutical companies, they have to be imported.
So
I'm not aware of the cost.
Cost, I don't know.
Yeah.
Maybe very expensive. So the concept now is that you don't wait for 1 year, 2 years and say, okay, patient is not responding. Like you said, you monitor them more frequently, maybe every 2-3 months. If there is no significant reduction in ALP and fibroscan or fibrosis scores are increasing over a period of time, add-on therapy seems to add value by pulling the disease back and allowing biochemical remission or biochemical improvement. So I think there's a great breakthrough in the treatment of PBC. We don't see much of it, so it doesn't impact us as much. But Basmani will know, in UK we see quite a bit, and they're very difficult to treat because there's nothing, and you just watch them deteriorate and then put them for transplant. But now these drugs are coming, and like you said, in the next 2-3 years, we're going to have 1 or 2 more drugs which can be add-on. Currently in India, the only thing you can use as add-on is obeticholic acid. It's still available.
It's still available.
It's still a good drug if used correctly. Certainly cirrhosis we should not use, and it can increase pruritus in a small percentage. So you have to look out for that. So it's still a good drug, and fibrates are also good. It's underused, but it's good. Obviously these will have a better impact, but fibrates are also good.
So regarding the GLOBE prognostic score, if the score is more than 0.30, the 10-year transplant-free survival rate is 60%. When the score is less than 0.30, the 10-year transplant-free survival rate is 92%. And regarding the prognosis in the primary biliary cirrhosis, men prognosis is poor. The age less than 30, the prognosis is poor. Regarding the action of the rifampicin, it reduces the action of the atotoxin. Thereby the level of lysophosphatidic acid is reduced, so the pruritus is also reduced. And one of the important factor for fibrate is it may produce acute kidney injury. That we have to bear in mind. And another is there are certain infective organisms, they initiate the process of that's called the molecular mimicry. That is rotavirus, chlamydia, pneumonia, and propionibacterium bacterium agnes. And even vaccination with lactobacillus has also produced this initiating event for primary biliary cirrhosis. And the Novosphingobia aromaticin vorans, that's one of the organism which initiates the process of primary biliary cirrhosis.
Thank you, sir.
Nowadays they are promoting it is same as UDCA or it doesn't have better effect.
I don't think it has been studied in this context. You want to take it?
I have not heard of that
It's
drug.
not been studied in this context.
There are just two components.
Sure, sir, sure.
They say it has got some action on the cholinergic mechanism.
Sure. I think it is going to be more like obeticholic acid, the effects on the patient. There are very few studies. Mostly they are looking at MSLD studies, but nothing for PBC.
Can you surrogate marker for AMA negative primary biliary cirrhosis?
So the GP 210 and the SP100, they are the surrogate markers, sir. Apart from in AMA negative, but they are only additionally 15% of chance that they may be positive. A liver biopsy may help in that scenario.
So regarding the antinuclear antibody, that is rim and membranous like antinuclear antibody is one of the surrogate marker for primary biliary cirrhosis.
Yeah, I didn't put the 2500, that was the Indian data actually. In reality, it's much lesser. We hardly see a lot of PBCs, and we only see them in end-stage liver disease. These, I don't think they are studied in DCLD patients. No, if they are decompensated, yes. Yes. Yes.
The so don't use the old melt or NEL. Yes. That is the official point. Melt 3.0 is good. And since it's a rare disease and it's got a prolonged course, when you're waiting for liver transplant, they die. Do you have any exceptional point can vary for this, like your other things like April syndrome, like that? You have the transition. You have the Stanley on last.
Pruritus, fatigue, melt exceptions, sir. I think time is running up. They're very interesting. Another big round of applause for Swati, sir. So, ethanolic liver disease is a dual disease. One we deal with the liver and the other one with the neuropsychiatric problem, no? Addiction, withdrawal. I remember my chief going to court for 2-3 years in UK because one of the patients jumped off the window during withdrawal, missed 3 days after admission and became paraplegic with spinal cord injury. So it's often missed because first 24 hours, 48 hours, suddenly, sometimes out of the blue the withdrawal comes in a very atypical fashion. So another important topic. Welcome, Dr. Vivian. Thank you.
Use of these drugs in cirrhosis as well, because that's a very tricky area.
A very good evening, everybody. So, I'm just coming as the last batsman, so I just have a few overs to go, and I think I'll keep it very brief and very simple as well. So, because I'm not going to talk as a psychiatry lecture, so I just keep it very simple. Because if it's going to be a psychiatry lecture, it's going to be very complicated, and people will run away. So, yeah. So, what we are going to focus on is only going to be about alcohol withdrawal and relapse prevention. So before we go into that topic proper, I would like to give you some ideas about addiction, and I mean, of course, I think and like you being senior doctors here, so I think you would be much more experienced in dealing these patients as well. But I would like to give some ideas on why this is important. So, like why this doesn't work. Okay. Yeah. And yeah, these are some topics which we'll be going through, and please don't get alarmed by it. So, like, see, addiction is no longer it's just behavioral problem. So now it is more viewed as a problem with the brain as well. So we have gone. I mean, psychiatry is not only about thinking about it's just problem with some some character or behavior. So now it's become more neurobiological actually. So and it affects how a person behaves, and also it causes changes in terms of the structure of the brain and also functioning of the brain. So that's where this addiction also leads to, and you can see all this diagnostic criteria in terms of craving, decreased control, physiological features, and then you taking the substance more than anything else. I'm not going to go into that in detail, but if you could see this number, so you could see this is the prevalence data in India, so you could see almost 15%, like 14.6%, and with alcohol. So it is like one of the second most prevalent substance after tobacco. So you can see how significant that is, and I guess the numbers could be even higher in, I think, probably in our state. And why people go into addiction or use substances? Because this is something which you many a times, like patients come to you and they say, well, I use because I have problems in my home, I have debts, and they come up with lots of reasons. We have stress. Well, stress is something which most of the times people say, is there any living being in this planet without stress? Even a bacteria has to undergo stress. It has to fight all the antibiotics which you give, or all the immune system which you have. So stress is going to be part of life. Whether you like it or not, nobody can be away or like free of stress, because sometimes people come with a very unrealistic expectation. I need to feel totally okay. Well, nobody can be totally okay. So that's something which we have to accept and live with. So and most of the times you see patients, they come up with, I have these problems. That is the reason why I consume alcohol. And sometimes people tend to have anxiety, and sometimes they can consume alcohol because the anxiety takes away that bit of the alcohol takes away that bit of inhibition. They feel less anxious, and then they are able to function better. So that is one of the reasons sometimes people take alcohol as well. So probably if you treat the anxiety, they may not end up there, or sometimes they can use this as a mechanism or a coping for their low mood. They feel low. That's what they show in all our Tamil movies. Like once some breakup happens, everybody goes, drinks, sings a sad song. So, well, if you are treating the depression, you don't have to use this alcohol, because alcohol makes you forget that problem momentarily, but eventually you land up in a full-blown depressive episode, and unfortunately you will be landing up in people like us, like probably psychiatrists. So, which I don't think is a right thing. And sometimes people also say, I don't feel sleepy, I'm not able to sleep, so I end up drinking. Well, because people have a very misconception, like thinking that alcohol helps with sleep. Yeah, alcohol can help you go to sleep, but then alcohol can cause fragmentation of sleep. So whenever you ask their partner who comes along with the patient, you ask them whether this guy is your husband sleeping okay? No sir, he often wakes up in the middle of the night. He constantly keeps waking up. So that is something which happens with alcohol. So people have a thinking it helps, your sleep completely. No, because it causes fragmentation of sleep. Only initiation of sleep it helps. So in the long run, it also causes insomnia as well. And then sometimes as an escapism, as I said, and and social isolation, and sometimes even personality factors. Some people like they just like the feeling of getting high, or they feel that reward. So why I'm saying all these reasons is, this is something which we can connect it during management, and what are the drugs which we can choose for each of these behaviors. So that's the reason why I'm giving these details. So yeah, I'm not going to go into this. And then impact of alcohol, I think we all know, and we are seeing every day in our news channels or newspapers, like all sorts of things are happening, like because of substance use, especially alcohol, like in terms of problems in relations, like societal problems, violence, like even homicides, like people consuming a lot of alcohol, eventually developing delusion of infidelity, they suspecting their spouses, and they that's one of the common cause of homicide as well. So many a times you see, well, somebody has consumed alcohol and then in intoxication he murdered his wife. You would see that in newspapers as well. So many a times this is also a reason this could have been treated actually. So many a times that is something which is also missed. So that is one of the reasons why I wanted to mention this slide, and also drunk driving, because I mean we have a lot of RTAs which happen in our country, and alcohol also is a major reason. And then alcohol independence can be a reason for a number of mental health conditions like psychosis, depression, anxiety, mania, and even including suicide as well. So these are all major mental illness which can be caused by alcohol alone. So, and then many times people say, well, I mean, I'm just wondering what is going to happen. Well, I mean, what neurobiology says is even a single use can cause addiction, and if at all, this is the probability of substance dependence after initial use. So, for example, with alcohol, like the numbers are 15%, but tobacco is like most addictive, which you can see is 32%. So it's one of the most addictive substance on this planet, and then it's very difficult to quit as well. But in terms of alcohol, the numbers are around 15%. So see, early exposure, you know, it sensitizes your whole neurobiology in terms of your brain circuits, your like, you know, all the neurons in your brain. In terms of, it acts as a cue. So the moment, even when, and it also causes encoding in terms of in your limbic system as well. So the moment you start taking it, and then probably even if you're abstinent for like for a long period of time, all it takes is another drink, and then all the circuits get, you know, stimulated, and then again you would relapse into alcohol. So that is the reason why sometimes you see some patients, you know, like they are abstinent for 5 years, sir. He was dependent, he was abstinent for 5 years. All he started was one drink, and then he landed up with, you know, in a rehab now. So that this is one of the reasons as well. So and as you know, alcohol impacts all these brain circuits in terms of reward. So because it has an impact on the reward pathway, so it causes a surge of dopamine, and then you want to take that substance more and more. Like, and also it impacts your judgment in terms of your like frontal OFC, orbitofrontal cortex, in terms of your drive, your judgment, all those things get impacted in the long run. It also impacts your memory in terms of hippocampus, and also it causes a lot of like emotional memory. See, whatever we like, see, even like when we teach students, we teach them in a very, you know, crack some jokes or make some like things, so that they have an emotional state at that point of time, and then even if they go to the exam, they are able to remember or connect with that emotion and then remember that better. So that is happens with because of our amygdala. So even with alcohol this happens. So if you are connecting alcohol with, you know, a lot of emotional states, so whenever you are in that particular emotional state, then you will start craving for alcohol. So that is one of the reasons why these brain circuits are also involved. So and well, I mean, you also see many times when people with alcohol dependence, you ask their family history, sometimes they would have some people in their family being dependent of alcohol. Well, you could argue saying, well, he grew up seeing that, so that's the reason why his son or his next generation ended up with this. But then there are also a lot of genetic changes which happens because of alcohol use as well. Because alcohol not only has an impact in terms of your digestive system, it also impacts at your genetic levels in the way some of the genes are expressed, and then some of the genes get expressed in a much more, you know, higher way, like increases relapse risk even after cessations, like persistent methylation and all this, like even like there are protective factors like BDNFs, like brain derived neurotrophic factors, so which is helpful for neuroplasticity. Neuroplasticity is like how well you adapt to any change, so in terms of your brain. So that this alcohol use in long run, it impacts your neuroplasticity, so in a way it puts you at increased odds of developing several mental health conditions. So this is something which you can see with alcohol. So yeah, and also histone acetylation, like it boosts expression of craving related genes, so which you can see. And as you can see, like these drugs and also this stress can reprogram this brain's gene expression, which eventually leads to, you know, persistent vulnerability even after you have treated the patient in rehab and all those things. So that is something which we need to be mindful of. And well, I think as sir was saying, like with their experience in the UK, but Indians, we tend to become more dependent on alcohol. This prevalence of this problem is much more rampant there, because even though in the West people drink alcohol, they don't become that much, because I've worked in acute inpatients as well, but many a times in the UK, so we don't see that many patients who are coming with problematic drinking. Even in psychiatric settings, I would say. So the thing is, there is, as you all know, I think you, you experts would be knowing about these enzymes much better than me. So in terms of enzymes like alcohol dehydrogenase or aldehyde dehydrogenase, which is responsible for alcohol metabolism, which we'll be talking during disulfiram when I'm talking about that. So these, and there are certain polymorphisms which happen in these enzymes, which are present in certain East Asian population, which they say is protective in terms of their alcohol, you becoming, after consuming alcohol, from you becoming dependent on alcohol, that is a protective mechanism, which is not present especially in the Indian population. So that is one of the reasons why Indians, we tend to become more dependent on alcohol once we start using it. So, and hence we are at a increased biological risk. So I'm not going to go into these changes. So, and then many times this is a common thing which you will say, sir, it's all in my hands. If I think, if I will stop in next second, next minute, next day. This is the common thing which every patient will come with alcohol dependence. It is, this illusion of control. They think that alcohol is under their control, but the reality is, alcohol is controlling them, which they fail to understand over a period of time. So many times, if you have this illusion of control, you think, well, tomorrow I'll stop, or day after tomorrow I'll stop, and it will keep on going, and then over a point of time, your whole neurobiological circuits in the brain are going to get hijacked, and you are no longer controlling alcohol. So alcohol is ruling your life, and you become a slave to this substance, and it impacts their entire family. So this is how this is something which is a phenomenon which we can see in number of patients. So initially it starts as a euphoria, you feel high after drinking it, you feel good, and then after a period of time you start taking more and more, and then once you stop drinking it, you become shaky, you become tremulous, you develop all withdrawal symptoms, and then to relieve that withdrawal symptoms, you start drinking alcohol. So that's how eventually it leads on to dependent. So this is how, and then many times people also say tolerance, I think many young, you could see probably youngsters, they will say, even if I drink one bottle, I can stay steady, which means it's a big, I am so, in Tamil we use the word gethu, so which means it's I am so good, my body is so strong, which just indicates that you become tolerant. Well, because more amount of substance is needed to have that desired effect, which means you are becoming my patient soon. So, and as I mentioned, this addiction can cause all of these mental health problems. Well, I could see when all dangerous conditions, in terms of suicide, aggression, violence, including sexual dysfunction. This is something which I use it to motivate patients as well, because young patients, because alcohol kindles the desire, but it takes away your performance. Well, so that's something which is major as well. So probably that is something which we can use. The reason why we have all this information is also we can use that to motivate, or probably give that information to patients, because some of these things could be important for them. Probably they would have been a newly married couple, so probably they're trying for a child, and if he's having sexual dysfunction, that's going to have a lot of relationship problem, and you're going to end up in a family court sooner or later. So I think to prevent that, at least this might be a good information. So, and yeah, this will be more for psychiatry. So, and as I mentioned, I already mentioned this as well. I think, what are the withdrawal symptoms? What are the complications? So withdrawal symptoms can be quite simple. Initially it can start with nausea, vomiting, or probably they might have some palpitations or sweaty, tremors, or simple headaches. So this can happen in the initial period. Once they have been continuously drinking alcohol, they stop it, in 12 to 24 hours you can develop all these symptoms, and then probably in the second day or 48 hours, that's when there is a risk of developing withdrawal seizures as well. People can develop a seizure episode with alcohol during alcohol withdrawal, and in the third day, which is up to 72 hours, sorry, about my mathematics. So, like the third day, you are increased chance of developing, if you don't treat the withdrawal, you're at increased chance of developing delirium tremens. So, a patient can be very confused, can be disoriented. You ask him where I am, well, I would say I am in San Francisco now, but it's Chennai. But I might end up saying, well, they will be in the hospital, or they will be saying they were at home, or we are in the temple, or whatever. So they will be disoriented to time or place or person. So usually it goes in that order. When it comes back in that order when the patient improves. So that can also be there, and then it can also be associated with some perceptual disturbance like visual hallucinations, or they might be seeing things. Most commonly they see like some fire coming out from the like the walls, or some devil coming out from the walls, some shadows coming out from the top of the ceiling, and then all these things can be seen, and then sometimes like they feel like there's somebody behind them, so they will be very, very restless. It is very real to them because they are seeing it. So many times it becomes like, see, we don't see it. I mean, if at all, if somebody comes and say, who is there, why are everyone looking here, because there is nobody existing, how would you feel? That's how these patients, when they are experiencing these symptoms, would feel, because everyone is saying there is nothing there, but the patient is able to perceive it and see it. So that's when it becomes very difficult, and that's when that sir was also mentioning about risk of suicide, because they act on this, because of this fear, they're trying to run away from the ghost. They might even end up jumping or like ending their lives, or they might even hear some voices which are commanding or telling them to do things, which is very, very dangerous. Whenever somebody has a command hallucination where the voice is telling them to do things and they're doing it, it can be a danger, because they can end up hurting someone or hurting themselves. So it can be very, very tricky. So that's something which we have to be, and they can be very irritable, so changes in their mood, they can be very agitated, and then as you can see, all the autonomic symptoms, arousal can be there, like tachycardia, like increased respiratory rate, hypothermia, hyperacusis, and all those things, and then all the other things I have mentioned as well. And then another entity is Wernicke-Korsakoff. So there happens memory problems, and then there also there can be ataxia, like there is some incoordination, or there can also be problems in terms of their eye movements, like ophthalmoplegia. So I think even during your exam preparations, I think you would have learned about like GOA or LOAs, like some global confusion, ophthalmoplegia, ataxia. These three triad make up for Wernicke's encephalopathy. But then most of the times these three are not always present. So that is something which we have to, like textbook thing which we don't see many a times. So that is something which we need to be mindful of. And when there is some confabulation as well, they form false memories because there are gaps in memories. So they end up filling the blanks with some memories which they don't do it deliberately. These are all unconscious processes which are happening. So, and that becomes a Wernicke-Korsakoff syndrome. So when in together. So and going to the topic proper. So now I think you would have all realized that I am a psychiatrist, because to come into the topic it took me a number of minutes. So yeah, and coming to the screening. So this is something which I think you can all ask your physician assistants, or I don't know, like your juniors or like your JRs to do. Like audit is a questionnaire, so which is something called alcohol use disorder identification test. It's a very simple questionnaire. So I think you can find it online. It is freely available, freely can be used as well. So it is a gold standard for identifying if alcohol use is a problem or not. It's just it does not give a clinical diagnosis, but gives you a suspicion that this person is more likely to be dependent on alcohol. So and if your junior or like your junior resident, or they say that the score is 20 or more, then you need to think about referring to a specialist like a psychiatrist. And then like there is also something called a very simple thing called audit C. It's just just few questions, just 3, because I know you're all very busy gastroenterologists, so you will not have time. So if you're not able to do audit, just keep it very simple. Audit 3. It's just some 3 questions, and this is also freely available. And if I'm happy to share that through email if at all, if anyone wants it. But then it's available in the public domain. So if score is 5 or more, then you should use the full audit and then probably refer to a psychiatrist. So this is just to screen if the patient has problems with alcohol. And what is the role of medication in addiction treatment? Because many a times this is something to do with your willpower, your motivation, your own behavior, your control. That's how people are talking about psychiatry in general. Forget about addiction. So things have evolved much more than that. So see, what are the role of medication is treating the withdrawal symptoms, that everybody agrees, and also about relapse prevention, which is, I think the whole topic is de-addiction, so I would say it as relapse prevention. So there are some medications to help with craving, which reduce the craving, and there are some medications which also reduce the rewarding effect. See, for example, we drink alcohol, you get a high, you feel good, it gives you a reward. So some medication goes and blocks that receptor, so you don't feel that high when you drink that alcohol. So what makes you to go on again and again drink? Well, even if you go on again and again drink while you're taking this substance, well, you're not going to get that high, and the person who is going to go for that high is going to probably come down on his alcohol use. And then there are certain medications to reduce the impulsivity as well. So yeah, and then treating the withdrawal, as I mentioned earlier. So there are few regimens in terms of treatment. So what I would say, for any non-psychiatrist, this would be a very simple method which we can use. So I think, because if at all, if you're going through a symptom triggered regimen, to use this SOS, so that the patient eventually doesn't land up in a complicated withdrawal later. So this is, this is quite self-explanatory. I'm not going to go into all those details. So, but if at all, if anybody wants to take a picture of it, they can. So, and this is a fixed regime for chlordiazepoxide, and which is available as Librium, throughout the world. I think Librium is the same name. And then this, if at all, even despite treatment with all this benzodiazepine, patient still develops complicated withdrawal, like withdrawal seizures. Simple thing is, we need to give IV lorazepam, which we give it as over IV, like 4 milligram, and after 10 minutes, if necessary, you repeat another dose. And then most of the times, sometimes people end up giving anti-epileptics like phenytoin and all those things. For withdrawal seizures, this is not necessary though. And many times when these patients develop this problem, you need to monitor these patients at least hourly for the next 6 to 14 hours, at least half a day. Just keep it that way. And then when this happens in a hospital setting, it can also be indicative of, well, the patient is in severe withdrawal, or the way we have treated the withdrawal is not adequate. So the reason why I am putting this is, probably if this happens in a hospital setting, because even India is moving towards that culture of where people end up suing the doctors, and we need to be very, very mindful or be careful about it. So I think this can also be a potential ground. So we need to be very safe around this. And then if still the withdrawal, this is a very dangerous complication in terms of delirium tremens, which can happen around the third day. So whenever some patient he gets admitted, just ask when is the last drink, and then if they say, well, if they're still in withdrawal, probably after 2 days as well, then this is something which you can expect immediately. You'll have to aggressively treat the patient, because this can happen in around 5% of alcohol withdrawal, and the mortality rate is around 10%. And then there are some studies which say even numbers go up to 35. So that is very alarming. So this is one of the conditions which we need to be very wary about. And then it's a preventable complication of withdrawal. And this can happen even up to 5th day of withdrawal. Sometimes it doesn't classically happen in the 3rd day, sometimes even up to 5th day as well. So this is something which we need to be very careful about. And whenever these are some risk factors which are present, then we need to be very careful that it's likely that a patient might end up with a delirium tremens, like if there is a previous history of seizures, or if there is a low potassium, like hypokalemia, And then like any if there are any systemic diseases which can increase, like probably any metabolic conditions and all those things, and then any physical health problems, and if there is also deficiency of thiamine, and then low magnesium. So off late I think this is also a well researched area. So this is emerging, like where they say low magnesium, it also puts someone at an increased risk of even Wernicke, including delirium tremens as well. So yeah, and these are some symptoms which I have already mentioned, but I'm just trying to go through again. Main thing is confusion, disorientation, like all the autonomic arousal symptoms like fever, tremors, and sometimes paranoia as well, like people are out to harm me, or people are out to get me, people are stealing things from me, or they'll be very agitated, and then there can be auditory hallucinations, visual, and even olfactory as well. So, and then people can have sleeplessness. But when you have all these things, you should also rule out other cause of delirium. So like if there is any subdural hematoma, like doing a brain scan, or if it is because of a Wernicke's encephalopathy, or if there is a hepatic encephalopathy, like any hypoxia, or if there is any infection ongoing in your body like sepsis, any metabolic parameters which are problematic, or if the patient has been taking some drugs and then he is going through a withdrawal. So that is also something which we need to be mindful of, because many times people don't just use one substance, sometimes it can be other substance as well. So I'm almost through, I think. Sorry. Yeah, and how do you treat delirium tremens? So mainstay of treatment would be about treating those withdrawal symptoms, like through chlordiazepam epoxide, or it can be through oral or IM lorazepam. So, and then oral, well, some might ask, why not oral diazepam? Well, some guidelines like Australian guidelines recommend oral diazepam, but I think the UK guidelines keep it very simple. So treat with oral or IV or IM lorazepam, or keep it as oral chlordiazepam oxide. So, and if there is agitation, and you don't have to use antipsychotics in these patients just because they have like all these like psychiatry-like symptoms. But the thing is, if at all, if they are very agitated, they are putting themselves at risk, or they are probably posing risk to others, then probably this is something which we need to consider as well, like adjuvant haloperidol in terms of oral haloperidol or IM haloperidol as well. So this is something which we can definitely consider. And why not other antipsychotics like risperidone, olanzapine? Well, evidence is more for haloperidol, and the NICE guidelines clearly says this is the only licensed medication for withdrawal rather than other antipsychotics. And coming to Wernicke's encephalopathy, so this is like as I mentioned, all this triad like ophthalmoplegia, confusion, and ataxia. It's an acute medical emergency, and any change in mental status, including delirium, can be a sign of this Wernicke's. If it's accompanied by history of poor nutrition, they have not been taking food at all, any eye movement abnormality or ataxia, and it has a high mortality rate as well, and can lead to, as I mentioned earlier, Wernicke-Korsakoff if it's not treated with this thiamine, IV thiamine. So, and we need to give a generous, which I will be talking in the next slide. So, because alcohol withdrawal and until this thiamine deficiency both can cause inflammation of the brain. So, what happens is like eventually both are together, then that's going to result in a much more chaos like this condition. And then in Korsakoff syndrome, as I said, there will be severe short-term memory impairment, so that there will be confabulation as well. So they will try to form new memories or false memories. And then in terms of long-term memory, well, it is quite variable in terms of its impact. So some can have that impact, some patients are totally okay. And how do you treat it? Like the first step is strict abstinence. Don't continue drinking alcohol more and more, well, because then that's going to be much more worse. And then because sometimes people say if you are in withdrawal or delirium tremens, go and drink alcohol, it's going to be okay. But in Wernicke, it's going to be a big chaos if you are going to drink alcohol. Continue to drink alcohol. And oral thiamine alone is not enough. So we need to give parenteral thiamine, like IV thiamine. The guidelines clearly say 300 to 500, and sometimes practically looking at it, sometimes we go up to even 300 milligram, TDS dosing, or even 600 milligram per day, 600 to 900. So, but the guidelines clearly say 300 to 500 would be adequate, 3 times a day for 3 to 5 days, and oral thiamine alone is not enough, because if that much amount of thiamine you give, like in terms of oral, what they say is like in repeated studies, they even for normal person, like only there will be 10 milligram per dose absorption. For people with alcohol dependence, the absorption is even going to be less, and then it's going to be much more less. And then if at all, if when you are giving this treatment, and what will happen is many times this cognition starts improving as soon as the patient stops drinking, and then will continue to improve around for 3 to 6 months over time. And then, I mean, Royal College of Psychiatry clearly says along with this, you can also, they say, like activities like daily activities, simple activities like what you do at home, like making your own food, like cooking, or even trying to do like simple household activities can improve cognition as well, not only medications. And then also and they say magnesium can also help in this condition. So I think probably it will be helpful to look at the magnesium level and then give a supplement as well. And if the patient is symptomatic after 5 days, continue this course of thiamine until they become better. Once you see until you see clinical improvement. So many times patients tend to ask, well, I mean, is abstinence necessary, or can we drink a little, especially patients with alcohol dependence problem. So whenever you have severe or moderate dependence, I think abstinence will be the rule. And if you have other medical conditions like your involvement of your liver or end stage liver disease and all those things, I mean DCLD and all those things, so then I think this would be the rule. And then if at all, I think alcohol is consumed by all genders. So I think for women, like if they are pregnant or breastfeeding, I guess safest approach is to not drink alcohol at all, because the risk to the baby is also quite high. And then low risk drinking, which they advocate in the West, is in the form of harm reduction. So not to drink more than 14 units of alcohol a week on a regular basis, and if at all if they are taking that, you need to spread that evenly over 3 or more days. And well, for this can be tried in people with some mild dependence based on the audit criteria, and people drinking at like slightly higher risk, but then not meeting the criteria of moderate to severe. And if at all if they don't have any other mental health conditions as well, this can be, and they have good social support. So that's when we can think about low risk drinking. And next will be the final topic will be about relapse prevention. So we have talked about withdrawal. So what do we do to prevent? So couple of drugs, just few more slides, I'm going to end it. So acamprosate, naltrexone, these are the two drugs. One is to reduce craving, which is acamprosate, and the other is to reduce the reward or the feeling of high which once you take alcohol. So that is what the second drug tries to do. So and one thing which we need to be careful about is acamprosate should not be given in people with renal insufficiency and also with severe liver insufficiency. So that is something which we should not be giving. So and the dosage, I think this is consensus from Maudsley guidelines. So more than 60 kg, give 333 mg 2 TDS. So if this less than 60 kg, 333 mg 211. But many a times it also becomes tricky, because patient says, 2 tablets, this I am taking, and then also I am taking omeprazole, all the other things you deliver, so other medicines as well. So how am I supposed to take? If at all, if they are not at least adhering to the first, then at least probably we need to think about, because India you need to adapt to certain things, because if taking something is better than taking nothing, so at least probably the second regimen is something which you can follow. And common approach is to prescribe for at least 6 months, and if it's beneficial, you extend up to a year. And then if at all if they are taking this and also consuming alcohol, then find out how much they are drinking. Has the drinking period or the duration has come down, or the drinking quantity has come down, then you can continue it. If not, then there is no point taking it after 4 to 6 weeks. Then probably you need to refer to a specialist and then stop this medication. And next one is naltrexone. See, this is also a good drug, but then this should not be prescribed for people who are using opioid medications, or they are using opioids, like as recreational drugs, like for people with opioid dependence. So if and even if they are using it, you need to establish that they have not used any opioids or any morphine or all these substances at least for 7 to 10 days before you can start this medication. And see, if there is liver failure, then this cannot be given as well. So, and it's, I mean, as you all know, this acts on the opioid receptor. It blocks on the opioid receptor antagonist. So it reduces the craving effect of alcohol. So even if they drink, they are not going to get that high, or the high is not that going to be there. And typical dose is around 25 milligram, and then we can increase to 50 milligram per day. Yeah, and then this is just a comparison. So if at all, if they are only drinking it for the sake of getting high, choose naltrexone. If at all they are getting craving, or they are getting thoughts, intense desire to use alcohol, then probably prefer acamprosate. And then second line drugs as per guidelines is disulfiram and baclofen. So in terms of disulfiram, I think you all know this blocks aldehyde dehydrogenase, accumulation of aldehyde. So that is one of the reasons why when patient drinks alcohol, then it ends up with all sorts of complications. So patients can have all the autonomic arousal symptoms, flushing, intense vomiting. So it can be a very bad reaction. So it's more of a deterrent substance. So but the thing is, you need to get some clear consent from the patient, from the family, before you start this drug. So it's a whole lot of procedures. So that is one of the reasons why those days I think commonly they were using, but even in the UK I think people were not using it much, but people in India, people do use, but then many times sometimes people are not willing to use it because they don't trust themselves. Because if you consume alcohol and then take this, it can also be fatal. So that is one of the reasons why this is something which I would not recommend. And if all these conditions if you have, then I think it's better to avoid, like avoiding stroke, ischemic heart disease, hypertension, psychosis, risk of suicide. And then it can be, as I said, it can have a rare complication of fatal, rapid onset, unpredictable liver damage as well. So, and if at all, if they have any psychotic conditions or risk of suicide, this can precipitate it. So it is totally advisable to avoid it. And this needs to be given under supervision. So probably some family member has to take that responsibility, because if not, then it's going to go to the dustbin and they're going to say, well, we have taken it. So, and then only if you have good family support, you need to go with this molecule. If not, I would strongly advocate against it. And then baclofen. So see, baclofen is a GABA B agonist. It can be used in a number of other conditions like hiccups and all those things, but it can also be prescribed as relapse prevention. But how it exactly works in relapse prevention, to be honest, even Dr. Steven Stahl, who is a pioneer in psychopharmacology, will not be able to tell you the exact reason for it, because some of these medications, why they work or how they work, there are lots of hypotheses, but exactly we don't know. So, but the thing is, it helps in relapse prevention as well, and it can be prescribed in advanced liver disease when compared to all this acamprosate or even naltrexone or disulfiram. This can be prescribed in advanced liver disease, and dosage is around 20 to 60. And one thing which you need to be cautious is like cautious use in epilepsy, or if there is a mood disorder, if the patient already has previous history or suicidality. And then you need to be very cautious in terms of down titrating it and stopping it. Same like other drug which I said, like you need to give this for at least 6 months, 4 to 6 weeks, see the effect. If no, then discard it. Yeah. And then what I came across, this is something which I have not encountered in my practice. There are people who also have baclofen withdrawal, which I have never come across, but then this is something which I learned when I was going through this topic. So I think, so that is one of the reasons why you also need to think about, like if at all, if they're asking more prescription, I lost my prescription, if they were asking frequent prescription, that is something which we need to be mindful about. And then also we need to reduce the total dosage by 5 milligram as well. So gradual reduction each week to avoid this withdrawal complications. So, and in special situations, almost done. So alcohol and opioid dependence, probably you can choose naltrexone. If there is also cocaine use, the Department of Health UK guidelines clearly say you can choose disulfiram, naltrexone or acamprosate. And then if it's like older people, because of their renal parameters coming down, they say choose naltrexone instead of acamprosate, because it's predominantly secreted through the kidneys. And then adolescents, because these days we also see that, because adolescents end up using substances even in India, and alcohol is also a major problem. So acamprosate, naltrexone, but in naltrexone can be only an off-label use. It's not as a it's licensed. So and it's not licensed. Sorry, advanced alcohol-related liver disease, then acamprosate, because it is excreted primarily through the kidneys. But first choice would be baclofen. And this is usually the cycle of addiction. So and why, I think first thing is assessing the patient, managing the medical condition, then thinking about psychosocial intervention, and then you work as a team, because you also would need a mental health professional to help you with during this period, and then to educate the family and the patient to think about relapse prevention, and then also think about regular follow-up as well. And so that would be my presentation. So these would be my references, and if at all there are any queries, I'm happy to answer them.
I think we are very close to dinner, so if anybody has any burning questions, we can take one or two, otherwise we'll close.
We use cage questionnaire.
Yes.
Or it is cage is orally
Yes.
reproduced,
Yes.
or it need a table column tablet like that.
Yes, sir. Yes.
And since we are using regularly baclofen for craving,
Yes.
you also now say is craving, it also can cause a withdrawal.
Yeah, yeah.
And third thing is an observation. We treat patients, we see them regularly, but once this alcohol comes, we see them once a year. So that's a wrong. They should be regularly seen,
Yes,
like
sir.
systemic hypertension, diabetes, liver disease. This point should have been.
Yes, sir.
Basically, patients don't take it for granted. We
Yes.
don't follow this part. That's the reason.
Yes.
And only small observation. If prohibition be helpful.
Well, I mean, see, I am not an expert or a public health expert on this, sir, but historically looking, I think prohibition has happened in the US as well at one point of time, and it was a big failure. Yeah, 1930s, sir, and it was a big failure. It grew up in the black market, and then everything started coming up. So I think, is prohibition going to be helpful?
See, in Gujarat, they come to your home and give it. In Gujarat, they come to your house and give the alcohol.
Yeah. Okay.
So you just phone them, they come.
Okay. Home delivery.
Thank you, Dr. Vivian.
Thank
it was a very interesting and great lecture. Thank you so much.
Thank you, chairpersons. It's a time to thank you all, thank Patton and TNSG office bearers and the participants, the speakers, for having a wonderful evening session. I would like to thank the postgraduates who have presented the case, and our speakers, Dr. Nirmala, Dr. Swati Raju and Dr. Vivian, for wonderful presentation. I would like to ask Dr. K.R. Palaniswamy to felicitate Dr. Vivian. Our guest speaker, Dr. Vivian. Thank you, sir. Thank you for enlightening us on alcohol dependence. I would like to ask Dr. Basumani to give away the certificates for the postgraduates. Dr. Kiran. I would invite Dr. Rajinikanth, sir. Dr. Ashwin. For call, sir. Emergency call. Oh, okay. Oh, okay. You can add it. Thank you, sir. Dr. Elancharian. Sir, you can give it. Dr. Perarsu Mohan. LED தெரியுதா? Okay. It's okay. Thank you, participants, and thanks Sun Pharma for supporting us this event, and Savera for giving the ambience. With this, we'll end this session today, and we'll meet on month of June. So next month we won't have having a TNSG meeting. Thank you one and all. Please join us for the dinner. Thank you.